Well, welcome to a Personalized Lifestyle Medicine Institute educational program. This program, I believe, is going to open up some new vistas as it relates to the interface among the immune system with the endocrine system, with the syndemic that we're starting to see as it relates to blood sugar problems and obesity, hormonal dysregulation in both women and men. This is, I think, a really interesting snapshot on both the assessment and intervention potentials that are emerging in this 21st century of systems approach towards personalized lifestyle medicine intervention. So with that, I have the privilege of being the introducer to the program, and our two extraordinary clinical faculty will join me for the next couple of hours with you, and we will hopefully be able to provide some important news to you. So with that, as a background, let me jump into the material of the day, and we'll get going here. And I'm very, very privileged, obviously, to have an extraordinary faculty to share this topic with you. Dr. Michael Chapman, Dr. Christian Jinsky. We're calling this the Endocrine Symphony, evaluating and supporting the organs of communication. This is the endocrine maze, so to speak, and there's a lot of piece parts to this discussion. I hope we won't be losing you as it relates. We try to make these interconnections, systems biology interconnections among these different systems, but our attempt is to unravel dysfunction that relate to this super system and improve clinical outcomes in patients that have chronic disturbances of their endocrine communication system. So, as I've said, we're going to develop individualized treatment plans for this program, distinguish the pros and cons of using various types of analytical samples from serum, salivary, and urinary hormone testing. We will be looking at biological hormone replacement therapy, looking at common assumptions around hormone testing, and recognize the various types of tests and which might be more applicable to different conditions, and then best practices around hormone kind of an intervention. So with that, as a broad-based series of objectives, I get the first half an hour to share with you some of the contextual overview of this topic, the topography, so to speak, and then we'll move into the more detailed discussion with Dr. Chapman, Dr. Jinsky, and then we'll finish up with a panel discussion among the three of us. It's always a very enjoyable part of these programs because it gives us a chance to explore these topics in, and I would say, a little bit more informal way as it pertains to what we've learned from the evolution of this field. So just a quick review of basic terms. I think all of us are well familiar with this. I don't want to insult anyone's intelligence, but we'll start with the kind of overview of the endocrine system, the hypothalamic gonadal system, but we recognize that it's really the hypothalamus, pituitary, adrenal, gonadal, thyroid system. This is all interconnected. It's a super system, the HPAT system, but we're also going to connect this into other members of this endocrine symphony, which includes the renin-angiotensin system, or sometimes abbreviated RAS. We will connect this also into the enteroendocrine system, and we will connect this into the immune system. So if we want to really talk about painting a big picture, a broad picture, that's the approach that we're going to be taking in this course, is to try to look at the interconnections of all of these systems as it pertains to how they display their function at the phenotypic level, a person, how they look, act, and feel, and where are these dysfunctions that might appear within the super system, and then how to intervene. So with that as a broad objective, let's talk about hormones of the endocrine system. And as you probably know, there are many, many different molecules that have been identified to be secreted and have autocrine, paracrine types of effects as a consequence of the signaling that occurs within the system, this mosaic. So in the hypothalamus, we've got gonadotrophic hormones, thyrotrophic hormones, corticotropic hormones, somatostatin, dopamine, vasopressin, oxytocin, which I'm going to talk about a little bit, coming from the pituitary gland with additional in this case, peptide hormones like thyroid stimulating hormone, luteinizing hormone. As you know, ACTH is also another important polypeptide hormone. So we talk about the different kinds of messenger molecules. They're both small molecules like the steroid hormones, estrogen, progesterone, testosterone, and their metabolites, but they're also large molecules, peptide protein-like molecules that participate in cellular signaling across different organ systems with different receptor sites that are activated by these molecules. So lots of different players in this portfolio of bioactive substances that regulate organs at a distance or function at a distance from signals that occur down through the central nervous system, through the hypothalamus and pituitary, which are connected to the visual system. So we think of things like the pineal gland with melatonin and being associated with the light dark cycles and sleep and different wavelengths of light that are that are impinged upon on the eye and how they transmit signals ultimately to the this broad array of substances that we control in some ways by our lifestyle, our environment, and our diet. So we'll be talking more about this, obviously, but to think that in 2 hours we can do a complete job in going through all this obviously would be a little overly ambitious. So we'll try to hit the high points as it relates to how this field of systems biology is emerging in both the assessment and intervention of endocrine-related disorders. Well, one of the principal molecular players that is, I think, on the tear sheet of all of our background and interest as it relates to the disturbances in the system is the steroid-derived molecule cortisol. As you know, cortisol has multiple pleiotropic effects across all different types of phenotypic outcomes, including the visual system, the nervous system, cardiovascular system, the immune system, the musculoskeletal system, the reproductive system, regulating various aspects of glucose-related metabolism, and the respiratory system. So it's a centrally important molecule that regulates so many different functions in our body, and it is obviously a downstream signaling substance that gets its message upstream from ACTH, from the hypothalamus-pituitary interaction. So this is all part of what Hans Selye helped us to understand way back in the 1930s, the kind of the father of what we call stress. He appropriated that term from physics and brought it into biology, talking about the connection to the HPAT system and the response that animals have to apparent threats or feelings of being unsafe or in a hostile environment. So if we really look at how the HPA axis reflects then different symptom profiles, and this is just kind of one example of that. This is a recent paper in the expert review of clinical immunology talking about malaise and fatigue associated with autoimmune diseases. And in looking at where fatigue and malaise come from, they're related to, in part, disturbances of the HPA axis. And that then ties together with alterations of the immune system, as we'll talk about, and in inflammatory status, and how that then relates to cytokines. And, you know, when you have a fever, you often feel very fatigued. You don't have a lot of energy because you are using up a lot of your energy in the activation of the immune system and its interrelationship to your stress management system, the HPA axis. So these are all interconnected in ways that I think are very important clinically to understand when we start looking at patients that express things like night sweats, or people who have low energy, fatigue, depression, people who have pain of a chronic nature. All of these, or including cardiovascular symptoms, hypertension-related symptoms, or symptoms related to sleep disturbances, or problems related to endothelial function. And all of these are intertwined intertwined into this HPA-T axis activity and its relationship to this multiple organ involvement. So let's look at where cortisol comes from just for a moment here, putting that as the centerpiece of this discussion. Just to remind you what you already know, I think about the anatomy and physiology of the adrenal glands, that there are these layers of the adrenal cortex that have different physiological activities, interestingly very enough. So if you look at the zona glomerulosus, it's related to the secretion of the mineralocorticoids, the members of the renin-angiotensin system and aldosterone. So we think of that related to electrolyte management and blood pressure management, but it also connects into the whole stress response. Second is the zona fascicularis, which is related to the secretion of glucocorticoids that include cortisol and cortisone and are interrelated into glucose metabolism and immune-related effects in that the immune cells have the glucocorticoid receptors on their surface. And then the zona reticularis that is involved with androgen production. This includes obviously dihydroepiandrosterone and testosterone, which then go downstream to be converted into a whole array of other molecules like progesterone and estrogen. So this particular series of different functions the adrenal cortex has, and then we go into the adrenal medulla with the classic stress hormones, epinephrine and norepinephrine. And in fact, if you look at animals under stress and you do histopathology on them, you'll find that these zones of the adrenal glands are hypertrophied when the animal is under stress. You get thickening of the various layers as they start to activate the cells to produce more of these hormones. So our environment, our lifestyle, all the things that we're exposed to, experiences in life, then actually influence the cortical function and the adrenal medullary function to actually be more upregulated in the expression of these particular messenger molecules. So this is a classic example of activity and function being tightly tied, and therefore Cellier really, I think, was the first physiologist to get us to understand that the environments in which we find ourselves, our lifestyles, the factors that influence us, he called them stress factors, the so-called through the general adaptation syndrome. He called it the GAS, general adaptation syndrome. You go through arousal into adaptation and then into exhaustion, the running out of gas, so to speak, GAS, that those are all related to adrenal functional changes as a consequence in the environment in which we find ourselves. So the symptoms of aldosteronism or corticism can be very chronic in nature and be associated with environmental and lifestyle factors. So we look at the network biology then of adrenal hormones, and we see it cuts across multiple different organs. And this leads us into assessment protocols, ways that you're going to be able to assess the activation or alteration of the functional status of these different components of the adrenal glands. This will be part of what you'll learn in more detail from our other clinicians in a moment. But I just want to remind you that the mineralocorticoids, aldosterone, the renin-angiotensin system, we think of the kidneys, we think of cortisol having a direct impact upon the liver, and I'll come back to talk about the liver effects and tying that to thyroid and adrenal function. And then we think of the classic stress hormones, epinephrine and norepinephrine, influencing liver, heart, and muscles. And then obviously the reproductive hormones, the androgens and their metabolites into the estrogens, into male and female hormone regulation. So all these are tied into the functional status of our adrenal glands. So it's a really important marker as we start to evaluate functional systems biology from an endocrinological perspective. And you're all familiar with the so-called adrenal steroidogenesis pathways, the chicken wire diagram, some people call it, the precursor to all these downstream small molecules that regulate these functions is cholesterol. And so cholesterol undergoes a whole series of different metabolic changes in these different tissues and through different cellular activities, ultimately then regulating through pregnenolone and into dihydroepiandrosterone and its sulfate, ultimately going into the mineralocorticoids like aldosterone in the adrenal gland, or cortisol, or androgens, testosterone, which, by the way, then gets further metabolized at target tissues like the ovaries, the testes, brain, bone, and adipose tissue. All have the aromatase enzyme that's capable of aromatizing testosterone into estrogen. So when a woman goes through menopause, she may lose 50% or more of her ovarian estrogen production, but she can pick up the slack somewhat by extra ovarian production of estrogen through the aromatization of testosterone in other tissues, like in her adipose tissue, in her bone, or her brain. So there are different ways that one can pick up some of the slack of the loss of estrogen from ovarian depletion. So if we look at one of the estrogenic hormones, that's estradiol. And so we think of estrogen having estrone, estradiol, estriol as the three principal regulating hormones from aromatization of testosterone and its metabolism. It turns out that estradiol has been found to have a very important feedback control mechanism on the hypothalamic temperature regulation. And that's why when a woman goes through perimenopause, she often goes through really very extreme changes in her temperature regulation with night sweats and as you know, these discomforts associated with body temperature regulation. So this all occurs through the feedback system through the hypothalamus and the temperature regulating component of the hypothalamus. Well, it turns out that there are a variety of different regulating substances other than estradiol itself that are involved with the regulation of the hypothalamic temperature control cells, and that are recently found as a family of peptide hormones that are including neurokinins. And these particular hormones play very important, or regulating substances play very important roles in this feedback regulation between the ovary and ultimately into the central nervous system and the regulation of temperature. So that's led a variety of individuals to think, well, maybe we could regulate the problems of estrogen depletion in the perimenopausal woman who then has night sweats and temperature dysregulation by improving or altering the neurokinin pathways and the way that then controls temperature. And so we do know that there have been the use of various SSRIs, which are the selective serotonin reuptake inhibiting drugs, to modulate menopausal-like symptoms. And then there's a new class of substances that are being developed and actually now on the market to regulate temperature control by avoiding estrogenic hormones. But I think, recognize that the ovarian estrogen synthesis is really broken down into two components of the ovaries, into two cell types. One is the luteinizing hormone production, and the other is a follicle stimulating hormone production from two different cell types, one being the theca cells that are driven by luteinizing hormone produced from the hypothalamic pituitary function, and the other, the granulosa cell, that is stimulated by follicle stimulating hormone, again, origin coming from pituitary hormone release. So this feedback control that I'm talking about as it pertains to stress hormones also interrelates to the hypothalamic pituitary connection to the gonadal function, and ultimately the conversion into androgens driven by luteinizing hormone, and then the conversion by the aromatase enzyme that I was discussing earlier into the estrogen substances by aromatization, which then has to do with the follicle stimulating hormone activation of the granulosa cell. So this plays important roles in when we look at conditions like polycystic ovary syndrome, in which this is generally an androgenic driven issue, that the woman has increased levels of androgens and decreased production through aromatase of her estrogens, and so she starts developing androgenic type symptomatologies. That could be hair growth, that could be hair growth, say in the upper lip or her face, or it could be loss of hair on her scalp, or it could be related to issues pertaining to obesity, insulin dysregulation. All of these are symptoms that coupled together with polycystic ovary syndrome, and has to do with, again, imbalances in LH and FSH driven through alterations in the HPA-G axis. So we'll be discussing that, because it again comes down to the appropriate evaluation of where this problem occurs for hormonal evaluation, androgens and estrogens, and their interrelationship with things like glucose tolerance and cortisol, and ultimately LH and FSH-driven effects on the ovarian cells. Well, as I mentioned, the pharmaceutical industry has been looking at ways to treat the perimenopausal symptoms by altering the neurokinin pathway in the hypothalamus that's associated with temperature regulation. And the first drug to be approved in that was in May of 2023, Veoza, which is a drug specifically designed to reduce the frequency and severity of flushings and night sweating spells in women, that then regulates temperature through this hypothalamic pathway, avoiding then estrogens. So it's interesting to see, as we looked at the clinical research on this neurokinin 3 receptor antagonist and its effects on vasomotor symptoms, that it seems to have a very powerful effect, reasonably well-tolerated drug, that's the first non-hormone therapy for reducing moderate to severe menopausal vasomotor symptoms. And so if we look at the literature that supports it, this is, as I mentioned, a very interesting new approach. And the thing that I would want to argue from a personalized lifestyle medicine intervention perspective is that it illustrates that if you modulate and modify the signals that the HPA axis is getting, reducing stress, increasing sleep, and having appropriate a diet that doesn't activate the immune inflammatory system, that will reduce then the alterations in this neurokinin kisspeptin system, allowing then better regulation of temperature, even in the face of lowering estradiol levels in the perimenopausal woman. So I think that there are ways of reducing the relative risk to the severe night sweats and temperature dysregulation if one then implements a very powerful personalized lifestyle intervention program: regular activity, good sleep hygiene, a diet that's more favoring the Mediterranean type diet, the stress management. These are ways of greatly reducing the need for other kinds of exogenous agents to modulate perimenopause. We know that very high cortisol levels and alteration in DHEA, which can be measured, by the way, in the hair, is associated with the symptoms of post-traumatic stress disorders. And therefore, we now recognize that when a person is in post-traumatic stress, they're kind of locked into the feed-forward cycle of hypercortical cortical function and increased stress hormones that kind of locks the body into a state of alarm, into a sense that it is not at rest, it's not at peace. And so this HPA axis dysfunction, as illustrated through PTSD, is associated then with higher levels of cortical hormones, cortisol, and stress-modulated function. And there's this crosstalk between the hypercortisol situation and neuroinflammatory signaling, which then causes all sorts of symptoms of mood disorders. And so they're all interrelated. The chronic stress with chronic neuroinflammation, alteration of the immune system, and then kind of a feed-forward cycle of, I guess you'd call it homeostatic dysfunction of the HPA axis. And so you have to break that cycle. Again, going back to my previous discussion about perimenopausal symptoms, a woman who then introduces lifestyle considerations or stress management, gets involved with ways of managing adrenal dysfunctions, is an individual who will then have less PTSD-like symptoms. And this is now kind of being studied from an epigenetic regulation perspective. We'll talk a little bit more about this later, but I think that there are some very important breakthroughs that are occurring now to help to better understand the etiology of PTSD and to intervene for it selectively through re-regulating the immune and nervous system and the connection that has also to the microbiome. So lots of new things emerging there. So this hypothalamic connection through CRH to ultimately ACTH production at the anterior pituitary, and it's driven of adrenal cortical function with the production of cortisol, is at the kind of the center frontier of all these conditions and become a very important part of assessment of where that person is, their morning cortisol levels and awakening cortisol levels, and are they in this kind of hypothalamic overdrive situation. And so we talk about both hyper and hypocorticolism being very, very important because it goes through the Cellier model of activation, which is hyper, into adaptation, and then finally into exhaustion, which is hypo. And hypo is probably the state where that person the bottom starts dropping out clinically. They start really having no energy. Fatigue is very present. They've gone through the arousal state, adaptation, and now kind of lost their reserve, and they're into the hypocortisol situation with neuroinflammation and depression and low energy and fatigue. So one can evaluate this by a comprehensive analysis of these hormones and to look at the clinical symptoms that are associated with these conditions. And that ties together, as I mentioned, with another part of our adrenal glands function, and that's the renin-angiotensin system. And as we know that the RAS, as it's sometimes abbreviated, has a very important role to play in modulating blood pressure and having direct impacts on pulmonary function and the whole nature of the mineralocorticoids through aldosterone having an important role on cellular function with regard to potassium and sodium regulation. So this stress modulated dysfunction can also pertain obviously to things like hypertension and changes in the RAS system and how it controls endothelial function and ultimately vasoconstriction versus vasorelaxation and blood pressure. So all of these are part of a super system that, as we're evaluating patients, we need to be very mindful of. If they have this polysymptomatic profile of disturbance across this HPA, TG, adrenal system function, then you know that you've got a very big opportunity for intervention as it relates to managing stress and the cortisol delivery and activity. So the RAS system is connected obviously to adrenal cortex function. And I think we've talked about its interconnection to angiotensin converting enzymes and ultimately into sodium retention with elevated blood pressure with low potassium. So these are kind of laboratory markers for activation of the RAS and the impact it has on mineralocorticoids through aldosteronism. Now, there's another part of the endocrine system I want to speak to that is not as commonly understood, but I think is gaining prominence, and that's the intraendocrine system. So we've talked about the HPA-TG system, and we've talked about the RAS system, and now we're talking about the ENT system, the endocrine system. This is a very important additional contributor to the signaling that ultimately relates to the regulation of function across multiple organs, including parietal cell release of acid from the stomach, pancreatic, exocrine pancreatic function, and also endocrine pancreatic function with regard to the beta cells, and insulin release and sensitivity, adipose tissue activity with the adipocytes and adipokines, muscle activity with myokines. The liver, we've already talked about, an important role in regulating liver function, cardiovascular activity, and obviously neurological activity through both the microglia and through the neurons. So this is the connection of these enteroendocrine system cells. And where do they reside? They reside in the gastrointestinal tract. And so the L cells are the source of production of one of the now prominent enteroendocrine hormones you've heard a lot about, gaining a lot of marquee level interest, which is glucagon-like peptide 1, or GLP-1, which is one of the multiple gut hormones produced by the enteroendocrine system. So this is another important part of our regulating system that really ties to so many of the functions of our body. So let's look at some of the enteroendocrine hormones other than GLP-1. We have ghrelin, which you probably know is again produced in the proximal small intestine. It has functions in appetite control. You have leptin, which you're very familiar with, that is produced by the gastric mucosa. It's an appetite regulating hormone, again, a polypeptide hormone. Somatostatin is produced in the stomach and small intestine. It's very important for signaling to the brain. That's part of the brain-gut connection. Remember that the gut is kind of the second brain, as we've learned it through Michael Gershon's book that he published a number of years ago. Cholecystokinin, or CCK, is another of the endocrine hormones produced in the duodenum and the proximal jejunal mucosa. Stimulates gallbladder contraction, inhibits stomach emptying, and appetite control. Gastrointestinal intestinal peptide, or GIP, produced in the proximal small intestine, and relates to insulin stimulation and gastric acid secretion. And we've already talked about glucagon-like peptide and PYY and oxanomodulin and neurotensin. These are additional neuroendocrine hormones that all regulate actions at a distance in our brain, in our pancreas, in our vasculature, in our gut parietal cell activities with releasing stomach acid and starting the appropriate digestion of protein. So very, very important part of our system that we are learning more about, that ties together again with HPA axis activities, because stress hormones have their feedback regulation on the enteroendocrine hormones and how they regulate things like blood sugar and inflammation. So these hormones of the gastrointestinal tract, it's another extraordinary and important part of the regulatory system that ultimately controls how that person looks, acts, and feels, how they respond to their diet and lifestyle and environment, and is also part of what we're learning now is very important to assess as we're pulling together a better understanding of that patient's chronic symptoms and how they relate to alterations in our endocrine symphony. And so you have different cell types in the gastrointestinal mucosa that release different types of hormones. The A cells, which are upstream generally in the GI system, produce things like ghrelin. The D cells are in the stomach intestine, relate to somatostatin. The enterochromaffin cells, which we're very familiar with, produce serotonin. About half of the body or more of the body's serotonin is produced by the enterochromaffin cells that sit in the small and large intestine mucosa. The G cells produce gastrin. The I cells produce CCK. The K cells produce gastrointestinal intestinal peptide, and the L cells produce the glucagon-like 1 peptides. So what I'm saying is different regions of the GI tract with different cell types that reside within our mucosa are activated by different functions and tie together then with different regulatory activities, but they're all intercommunicating with the HPAGT system. So all this is a super, symphonic orchestration of regulation. So we know that postprandial plasma GLP-1 levels have been found to be elevated in individuals following gastric bypass surgery. These are obese individuals who have low GLP-1 levels historically. Upon a Roux-en-Y bypass procedure that then alters the communication of their GI tract, and now the GLP-1 levels go up and improves their blood sugar control. So that ties together our GI milieu, and then that ties together the microbiome. What are the types of things going on in the microbiome that relate to activation of these cells within our GI mucosa that then stimulate the release of these hormones that then control things like blood sugar, the browning of fat with the weight loss effects that you see with GLP-1 agonist drugs, and insulin sensitivity like you see in type 2 diabetics. All this then puts the microbiome into the story along with the physiology of our GI mucosal cells and their interconnection systemically with our stress hormones and our HPATG system. So yes, it's an endocrine symphony. That's the point we're trying to make. And the gut microbiome then plays a very important role in activating certain regions of the HPA system, particularly the hypothalamus. And this is some beautiful work from Susan Erdman's group at the MIT, showing that there is this feedback from the gut-brain communication coming from the gut microbiome of specific members of the gut microbiome, specific types of bacteria that then induce the release in the hypothalamic pituitary area of what's sometimes called the bliss hormone, oxytocin. And so as this article points out, the human gut microbiome plays an important role in the maturation of the neural, immune, and endocrine systems. Data from animal models shows that the gut microbiome communicate with the host brain in an elaborate network of signaling pathways, including the vagus nerve. Part of the microbiome's influence extends to the behavioral and social development of the individual, and humans' ability to communicate with others is tied possibly to the composition of their microbiome and its communication through the gut-brain pathway to ultimately the release downstream of neuropeptide hormones that are related to sociability, like vasopressin and oxytocin. So this is a very exciting additional part of our evaluation with the mood disorders like depression or what Dr. Erdman calls sociability issues related to social contact that may have occurred as a consequence of this dysfunctions in the microbiome, the gastrointestinal milieu. It's communication then through these mucosal cells like the L cells, and how that then communicates to the brain and ultimately releases these mood modulating hormones like oxytocin. So very, very powerful kind of example of this feedback symphony of relationships. So I've really been describing the molecular links between endocrine, nervous system, and immune systems that occur, and how stress plays very centrally important roles in modulating this whole pathway. So you see changes in all sorts of different hormones, cortisol, norepinephrine, inflammatory cytokines like interleukin-1 beta, hormones that regulate different functions coming from the pineal like melatonin. All of these work together in regulating function, and they can all be disturbed. That's why a comprehensive analysis of looking at where the problems lie is a very important part of the assessment of these conditions. So the immune system is connected then to our endocrine system through the production of these cytokines and modulating substances that regulate the central endocrine system's function through CRH and ACTH and cortisol, all a feedback process. that ties inflammation of the immune system together with stress. And so you want to deal with your inflammatory contribution to the stress modulating pathways as part of this network functional medicine or lifestyle intervention that we're going to be using managing these patients. And that helps to build then the appropriate network. We also recognize that outside xenobiotic agents can influence as these steroidogenic mimetics. We know that we now have over 50,000 new chemicals that have been put into our environment, some of which are mimetics of hormonal signaling molecules and modulate then the feedback processes through the HPA-TG system. And so we need to be very cautious to look at toxic imbalances of what are called adverse outcome pathways from the exposure to toxic chemicals. So that brings our detox concepts together with our endocrine management challenges. So we know that exercise, diet, and nutritional intervention play very important roles in modulating these complex processes associated with stress, inflammation, and hormonal balance that are associated in women with ovulation and reproductive viability. We see this obviously with PCOS, polycystic ovary syndrome, which is increasing in its prevalence. And we recognize that this requires a complex intervention program for the woman. It's not a single hit. There's no single drug that can successfully treat PCOS. Now, we do know that metformin has been used with some modest success to reduce symptoms, but it's not the panacea and certainly the be-all and end-all. It requires a much more comprehensive lifestyle interventional approach that we've been describing through this modulation of the endocrine symphony. One of the interesting nutritional agents that's been studied extensively for modulating this PCOS symptom profile, the hyperandrogenicity, is myo-inositol and D-chiroinositol that are both part of the B-complex nutrient family, but have specific influence on modulating these androgenic shifts that appear in women with PCOS. So this recent review was talking about myo-inositol and D-chiroinositol involved with the core of biochemical processes governing the transitions inside cells. Data is showing that they are able to transduce insulin and other molecular factors associated ultimately with the connection between stress hormones, endocrine hormones, and glucoregulatory hormones in women with PCOS, and help to strengthen aromatase production of estrogen from androgens, which is, one of the cardinal objectives in managing PCOS. So just an interesting example of how nutritional factors, dietary factors may serve as modulators of steroidogenesis and, in this case, the androgen to estrogen conversion. So this becomes part of the 2023 International Evidence-Based Guidelines for the Assessment and Management of PCOS. And I think what we're starting to see is some really important progress being made to first recognize that this is a much more prevalent condition than was previously acknowledged. And secondly, that there are things that could be done to affect it that does not necessarily require pharmacological intervention. Lifestyle intervention, personalized lifestyle management becomes a very, very important part of intervention as it relates to PCOS, improving insulin sensitivity, reducing inflammation, improving adipocyte regulatory functions so that you get lowered pro-inflammatory adipocytokines. All this becomes a very important part of the personalized lifestyle intervention for women with PCOS. And that also ties together with autoimmune-like symptoms, which we think of as interconnection between things like PCOS and thyroid dysfunctions, and that this is once again reflective and symbolic of this web of interaction of all these different organs and their different signaling substances that translates into things that then have immunological sequelae downstream. So I hope that what I've done in this is to kind of help you to understand that there is this feedback interface between all these different functional characteristics, our gonadal androgens and estrogens, our cortical functions of stress hormones, our hypothalamic and pituitary hormones, our regulatory functions as it relates to hormones like melatonin, and how that ultimately translates itself into things like immune system function and cytokines, inflammatory molecules that then serve to feedback into the dysregulation. So with that, let me, if I can, just thank you so much for the opportunity to introduce this topic and how we really think of this as a network, and how these processes are all interrelated and require us to assess and to think broadly across these multiple organs that are involved. So this is truly a symphony. And now we'll move to our clinicians who will help take us through the assessment and better understanding how to differentially understand the individual so that we can personalize therapy. Thanks so much, and I'll be back with you for the question and answer period at the end. Thanks so much.
Hi, everyone. Thank you for joining us for this PLMI event. Super excited to be talking here. Thank you to PLMI for letting me speak on this subject. My name is Michael Chapman, and I'm super excited to be talking a little bit about the overall endocrine symphony and how we can evaluate and support the organs of communication, especially in this ever-growing field of the endocrine system. And like all fields, we're just learning more and more every single day, it seems. So with that, I want to get into what we're going to talk about today. So some of the objectives for today is to distinguish the pros and cons of serum, saliva, urinary testing options. This is one thing that I think we've been talking about for so long, and yet we still are learning more and more about this. I'm going to talk about common assumptions around hormone testing, try to test some of those. Talk about what tests might be, where to start, what are some of the tests that are going to serve needs for the patients, and understand really the kind of the best practices around hormone assessment and what it can tell you. And so this is a great quote that I think encapsulates a lot of the discussion around hormone testing, ironically. And even more ironically is that this quote is often attributed to Mark Twain, even though it wasn't Mark Twain who said it. It's actually scholars now think that it was maybe from famous writer Josh Billings, but then other scholars came along to say, no, it wasn't Josh Billing, it was somebody else. And so just like in medicine, health, or any type of research, we're constantly testing our assumptions. And so for the meantime, I'm just going to take credit for this. So it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. And I think that's a good way to start this talk today. By now, I'm sure a lot of you are familiar with a lot of the symptoms of hormone imbalance. And what I'll say is that I think before you decide to run any lab test, it's important to figure out why you want to run it. Because there's a difference between checking someone's baseline levels before treatment, or managing their dose, or even changing what hormones they might be on. So understand why you're running any sort of test. And with that, it takes a really good clinical picture to be able to even know where to start with some of these patients, because a lot of these symptoms can be vague. They can have multiple causes, hormones being one of those. So just always keep in mind what's the clinical question you're really trying to answer with a test. It's always good to remind yourself that hormones don't operate in silos. They're always impacting each other. Sex hormones impact thyroid, thyroid impacts cortisol, cortisol impacts sex hormones, and on and on. And so the key is really balancing all of these, because there's so many different feedback loops from the top of this pyramid down and from the bottom of this pyramid up. It's bidirectional. And so just understanding that every time you make a small change in something, it's going to change and have an effect on everything else in the system. And that's what makes functional medicine and systems medicine really some of the most exciting and interesting work to do, but sometimes some of the most challenging work to do, because there are so many factors. So just starting with the base of this pyramid, keep in mind that really metabolic health is all about energy management. But it's also about adaptability. So the body wasn't designed to operate on like one same percentage of macronutrients all the time. It wasn't always designed to operate on 60% carbs to, 60-40-40 or anything like that. It's made to adapt. And like anything in your system and in your body, it likes a certain amount of stress. It makes it more adaptable, which is why sometimes doing a fast or doing time restricted eating, or even going from more of a ketogenic state to a more carbohydrate energy state. Um, Oscillating between these things is actually what the body is probably more likely to be used to and helps create metabolic flexibility. And so there are some key markers for looking at metabolic health. I think of the fasting insulin, the triglyceride to HDL ratio is very good, uric acid, and certainly inflammation and oxidative stress plays a role in that as well. But we're mostly talking about sex hormones, thyroid, and adrenal today, but I couldn't leave out talking about metabolism because, as you can see, it is at the base of that pyramid. So going one layer up, HPA axis function and adrenal function. I mean, I like to take a step back and say, when you think about poor adrenal function, what is the first thing that comes to mind? It's stress, right? But then let's ask another question. What is stress? And so I kind of categorize for patients that stress is really, at the end of the day, it's life events that are outside what our daily expectations have prepared us for. And that might sound a little complicated, but I think it kind of shifts the picture because it's not so much about things that happen to you or to the patient. It's really about what you are prepared for, what you are expecting. And in a way, it's kind of about flexibility as well. And so keep in mind that stress is a relationship with our stimulus that comes in from the world as well as our expectations. And sometimes the stimulus can't be changed, which is when maybe we might try to focus more on changing the expectations too and how to manage that. And then, of course, also stress, we can talk about inflammatory stress as well, and the stress that comes from infection. But the more I have learned and thought about this, I really do like to make the point that the adrenal gland, in my mind, is really a gland that craves routine. Because routine is the opposite of an unexpected thing happening in your life. And routine is almost like the counterbalance to stress. And so I have been finding myself talking a lot to patients about the importance of routine and really just setting out pieces and parts of a daily schedule or weekly schedule that is exactly what your mind and body are expecting to. And, the consequence of poor routine is really HPA axis dysfunction. And this ultimately can create what we call a disturbance or an imbalance in anabolic catabolic balance. And the way this really works is that stress creating cortisol and releasing cortisol, that is a catabolic trigger. And anytime that you have excessive catabolic triggers being released, it suppresses anabolism. It suppresses our androgens like DHEA and testosterone, which are responsible for growth and repair. And so over time, stress signals lead to catabolic physiology. Things like breaking down our bone, breaking down our muscle, breaking down our immune system, osteopenia, sarcopenia, immune suppression, certainly can lead to changes in our overall way we store energy, leading to abdominal weight gain in particular, water retention, and low libido. So the flip side of that balance, right? Those are all kind of breaking down in a bad way. Androgens serve that opposite role. So it can be super important not just to think of what is cortisol, but more so, how is cortisol and the androgens being balanced with each other? So again, when we're thinking systems, we're not just looking at these hormones in isolation, right? We always want to think about the relationship because you can certainly be on one side of the scale heavy. So you could have too many androgens as compared to cortisol. If you don't have enough cortisol in your body, that can certainly lead to major issues as well, and vice versa. As we more common in probably today's society have too much cortisol compared to our anabolic hormones. Moving another layer up, we think about thyroid. To me, big picture think about thyroid is kind of like a cellular thermostat. It serves as an upstream regulator of anabolic energy use. And so this is more so at a cellular level. This is the energy use within inside a cell, things to control like thermal regulation or anabolic processes like tissue growth and repair. And keep in mind with any one of these hormones, we have to think about tissue sensitivity, right? So there's always a balance between how much hormone is running around in the system, as well as how many receptors are adapting to that level of hormone, and then even whether there's things that are being told to ignore that receptor, very similar like an insulin resistance. So tissue sensitivity, especially for patients who are on hormones, becomes a big part of the conversation, I believe. So another thing is that the thyroid is highly susceptible to cortisol and adrenaline. There's a feedback loop that basically the higher your cortisol level, the more it inactivates a lot of the free T4 that's around. And so it can turn it into reverse T3. It has other feedback loops as well. So you can see where there's that interrelationship based on this pyramid that we have on the bottom right corner. So then we have sex hormones. And when I think about how to manage sex hormones, I, again, like to go a little bit big picture and think, all right, what are the inputs and the outputs? Because a lot of people are familiar with either testing hormones, seeing they're low, and giving either a bioidentical hormone therapy or something that is equivalent, like a phytoestrogen or something like that. But really, want to think about first and foremost, what are the inputs? How are these hormones being produced or not produced? And how is that production affecting the feedback loops, telling your hypothalamic pituitary system to decrease production of hormones or the hormone precursors? Then you think about metabolism, right? How effectively are these hormones moving about the system? What's the tissue sensitivity again there? Is it being bound up by sex hormone binding globulin and things of that nature that's making the circulation of it? Maybe the actual free levels are fine, but they're not being as effective because of the binding proteins. These are metabolism issues. And then lastly, what's the output? And that's where we think about the detoxification pathways, phase 1, phase 2 in the liver, and then even phase 3 in the GI tract, the urinary tract, and the skin for the purposes of elimination. So where could there be dysfunctions across this timeline? Really, at any point, right? And so if we're not thinking kind of this big, then we might be missing a part of why either our hormone therapies aren't working, or even the root cause of why someone has hormone imbalance to begin with. And there are a ton of things that regulate the sex hormones in particular, and really the hormone cascade overall. I'm not going to go through this list, and I'll say this is even just an abbreviated small list compared to all the things that can regulate the hormone cascade. Here's another example of just how many of these inhibitors and activators there are within the steroidogenic pathway, starting from cholesterol at the top left, feeding all the way down to the bottom right into our estrogens. Look how complicated it is. So one thing is you can use this type of evaluation and knowledge, though, to start to look at the overall steroidogenic pathway from the standpoint of where might there be backups in this highway, so to speak. And if you see a common pattern, we start to see patterns that are, this might be an obesity inflammatory driven backup. They tend to hover in this type of area, or this could be more of an estrogen dominance type situation, or this could be more of a classic pregnenolone steal type of imbalance we're seeing here. So seeing the way that these pathways are laid out, and actually getting patient results laid on top of it can certainly help you to piece together the whole hormone picture. So I want to spend a second just talking about sample types, and what they mean with respect to clinical considerations. We have serum, we have saliva, we have urine, dried blood spot available. Anything that the future might provide us is certainly on the table as well, and we need to be aware of. But let's start with serum testing. So historically, we've always thought of serum testing as reflecting bound and unbound hormones, which is why we refer to a lot of these hormones as total, right? We have your total T4, your total testosterone, things like that, because it's a combination of bound and unbound hormones. Now, we also probably have the most amount of research on serum testing compared to other matrices, and that's just because it's really been around for a long, long time. And with serum testing, because many of these hormones, I would say the overwhelming majority of them are bound by other binding globulins, you have to know the binding capacity of these. So progesterone is bound by corticosteroid binding globulin. Androgens, estrogens are bound by sex hormone binding globulin. Also, albumin can bind steroids, but it does have a lower affinity for them. It generally, I think of albumin as being around to buffer major fluctuations, and then the more specific binding proteins tend to work at those lower thresholds to make sure that there's the appropriate availability for the target tissue. So this paper has done a lot to create some of the strong opinions about the relevance of serum hormones, especially around bioidentical hormone replacement therapy. And there have been a few other papers that have come out in the past 5 years, which have tried to support this message. And I just want to spend a second taking a look at it because it was kind of a landmark study. And one of the things that was said in this was reliance on serum levels of progesterone for monitoring topical doses could lead to underestimation of tissue levels, which is, if you haven't heard a lot of the conversation around blood testing, serum testing, we get kind of this thought of if somebody's on hormones, then hormones just don't show up in the blood. And I want to just take a little bit of a deeper dive into that. So with this study, participants had been on topical progesterone for 2 weeks, and they did testing on the last day of the study after those 2 weeks, had not been on hormones prior. And so there are a few charts on this article that demonstrate the differences in serum progesterone versus salivary. And so you can see the axes here on the left. And in the blood, it looks like, or in the serum to be more specific, it looks like baseline is kind of around a 0.5-ish. You can see those first few black dots hovering there. And then it's just kind of a little bit of a bounce up into the 0.6, whereas the saliva study on the right-hand side, you can see where that hovers around what, so a 2, and then it jumps all the way up to a 3.5, which looks, like a pretty dramatic jump. Seems like people really showed a lot of the supplemented progesterone in the saliva. Now, I will say that this is an important study because it's a main study that referenced the claims that topical hormones don't show up in serum. And on the left, you certainly don't see much change in response to application. However, the thing I try to point out is that the raw concentrations of any analyte must be interpreted within the context of the matrix, meaning if you think about your standard chem panel and you're looking at potassium or magnesium in the blood, obviously that is a very different window in which the body tries to keep that regulation as compared to what you would find in, say, an RBC magnesium or potassium. We know that those tend to be more of a reflection of the overall nutritional status, nutritional intake of those minerals. So the matrix has its own kind of reference, and we have to think about that as compared to when we're comparing it to another matrix. It's not, what's the raw value that it jumped from 1 hour to another or 1 day to another. It's really about what's the normal steady state and how big is that jump compared to the normal steady state. And so that's one thing that I'll say with respect to that. And it doesn't imply that you only measure analytes in the highest circulating pool. Just because a ton of your serotonin is produced in your gut, and we know that only 1 to 2% of serotonin produced in the brain, it doesn't mean, well, we just measure serotonin in the gut, and that gives us a reference for whether they're making serotonin in their brain. That's right. We have to understand these matrices are very different from each other. So I try to not think in terms of best and worst when you're thinking about what matrix to use. I think in terms of what each measurement is trying to tell you. Your gut-derived serotonin has a very different role than your brain-derived serotonin. And I think there's ample evidence to suggest that, and use that same type of thinking across any type of analyte or hormone or what have you that you're testing. But going back to the question of does topical hormone show up in serum? So I found this study from 2000, and it looks more like it's from like 1940, but in this study, they actually took postmenopausal women who were not on hormones and gave them a 42-day regimen of topical progesterone, right? So they had a baseline, which wasn't done in the previous study, and then basically they gave them 42 days of topical progesterone. And as you can see with the graphs here, you have, like it says, there was a demonstrating systemic absorption of the progesterone had occurred and that the area under the curve was significant, as well as you can see there between days 1 and days 42, a pretty dramatic increase in the progesterone showing up in the serum. Here's another study, did a very similar type of method. You can see pre-treatment levels there on the left of progesterone, and then days 1, 8, 15, 22, 29, pretty different compared to that baseline. So I do think that there is evidence to say that hormones can and will show up in the serum. Now, another thing that we hear is serum levels do not reflect tissue levels. And so the logic here is that when you give somebody hormones and you test their serum, then you don't find that those levels rise to premenopausal luteal levels. But when you measure saliva, you do find that they rise to luteal levels. And so one thing I would say about this is that oftentimes the same dosing of progesterone does show anti-proliferative endometrial effects in studies, right? So what they oftentimes will do is they'll give a hormone, they'll test the salivary levels, they'll see that there's luteal, and they'll also correlate that to anti-proliferative endometrial studies, but they never test serum levels. So back to our original point, it's quite likely that if it is showing up in the serum, albeit perhaps not to a luteal level, that might be a level that is protective enough to create anti-proliferative endometrial effects. So again, going back to things might circulate at different levels in these different compartments. That doesn't mean that one is necessarily better than the other. It just means you need the right ranges to understand what's going on. So I will say that levels of progesterone found in saliva do appear to increase rapidly following application, but return to baseline over 12 to 24 hours. So there's a really large pharmacokinetic component here that you have to take into account too, especially around testing, making sure you know exactly when that person took their last dose, because that can be a major driver. Moving on to androgens for a second in the serum. So overall, they tend to be more lipophilic than estrogens, and testosterone tends to be a little bit more lipophilic than estrogens. And topical testosterone and serum measurements actually do correlate pretty darn well. It's best to test within 8 hours of the most recent dose. And so we typically don't see as much issues or conversations around people measuring androgens in the serum, even if they're on androgens like testosterone. Also to note, DHEA and DHEAS are very similar markers in the sense of figuring out an overall assessment of DHEA. They do correlate very well. So DHEAS is what you typically will measure in the serum. DHEA is what you typically measure in saliva. Okay, so let's talk about estrogens and serum evaluations for a second. So estrogen is even less lipophilic than androgen, so we tend to have even less confusion as well. But there's also not a lot of studies looking at topical levels of, topical estrogen supplementation and salivary collections. So I would say with our patients who are not on BHRT, serum is a perfectly appropriate way to measure estrogens. And even as you can see here, the jump between estradiol and estrogen after giving supplementation was pretty darn substantial looking at the serum. So I was not able to find a study like this. This was unfortunately oral estrogen as compared to topical. So I wasn't able to find any studies on looking at a similar type of study using topical applications like a Biest. But I will say that looking at some of the results of patients, their serum results of them on bioidentical hormones, this person was on both topical progesterone and estradiol. You can see those likely reflected there. We can't know for sure. Here's unfortunately on unopposed topical estrogens. You see those high levels there, as well as progesterone not showing up. And then lastly, progesterone only. So obviously I don't have baseline results here listing them, but we do tend to find that they seem to show up in the serum. And one other thing to note about serum testing and looking at hormones just in general is that, of course, serum hormones do change across the age. Across our production of them does change quite dramatically, maybe a little bit more so for females than for males. And so it's important to always, whether your patient is on hormones or not, put them in the context of their overall menopausal status and their age. And when you lay out this pathway, you start to see a larger picture of kind of how this pyramid is lopsided. The androgens are being driven down at a higher level in this patient into the estrogens. So this is just a really great example of how you can start to see how these things are working together, right? So in this case, aromatase for this patient is likely driving this lowered production of estrogens. You see DHEA is low, testosterone is normal, but then you have these higher levels of estrogens. And so ultimately you can see where the metabolism portion, that base layer of the pyramid, is having a dramatic effect on the hormone cascade. So this is just another example of like, take the whole picture together. It's much better than just trying to isolate serum sex hormones or just sex hormones, sex steroids in general, or just focusing on thyroid, right? We have to understand how these things are all working together. So just a note about salivary testing. In saliva, we're measuring mostly unbound hormone. It's really great to assess diurnal patterns like cortisol and changes in melatonin across the evening and sleep periods. One thing to note is that gingivitis, bleeding gums, can lead to high levels of the hormones because if you bleed into a sample, you're going to be producing a lot more hormone into that sample. So that's one thing to really be aware of. It's kind of gets us tripped up quite a bit. So going back to the graph before, the assumption is that salivary testing is more accurate because we see this sort of dramatic increase in salivary progesterone. So I mentioned this before, but the time since the last dose does have a large impact on the interpretation. Like, look at that dramatic up and down motion of the salivary progesterone in response to application. And so if you're doing serial testing, that's certainly one thing to keep in mind, and that even location of application can have a big role, whether somebody's applying hormones on their thigh as compared to on their arm or armpit or where else they might be applying it. Contamination can be an issue, and there's one thing that's super interesting is that individual people secrete hormones at different rates into the saliva. This was a study that refers to the saliva to blood secretor differences, and it demonstrated that when you control for dried blood spot, there's a tremendous interpersonal variability in how much hormone a person secretes into their saliva, right? And are we seeing that because dried blood spot doesn't reflect hormone status? Probably not, because this study was not done on people supplementing with BHRT, right? These were sort of normal individuals, quote unquote, and they did both their blood spot and they did their salivary testing, and they found dramatic differences between those two results within one person. So this suggests that there's some sort of mechanism that controls how much hormone a person might be secreting into their saliva. But the good news of that is that people tend to be very consistent at how much hormone they secrete into the saliva. So if you're finding salivary testing useful and you're not finding crazy numbers that don't make clinical sense, then that person is likely, you probably can use salivary testing for that person because they have a consistent production. Now, it might become more challenging if somebody is a high secretor of hormones into their saliva, and they're likely to always be a high secretor of hormones into their saliva. So you might choose a different method. Okay. One thing about some of the conversation around saliva reflects tissue levels. I talked a little bit about this earlier, but the logic is that physiologic doses result in symptomatic improvement and histological changes. Okay, there's one. Physiologic doses can lead to salivary results that approach follicular and luteal levels, although, as I just said, that can vary dramatically person to person. But if all things being equal, the logic there is that therefore salivary results are equal to tissue levels. And we have to ask the question, is that always true? Well, I mean, I just said there's one major variable in secretor status. I would say there's a major variable in the tissue distribution and the preference of that hormone to certain tissues, where the application is happening, and certainly the solubility of each hormone, right? We might see something dramatically different for more fat soluble or more lipophilic hormones like progesterone as compared to testosterone and our estrogen. So just say always be careful about the assumptions that we're making. And always remember that during perimenopause, hormones rapidly fluctuate day to day. So in that circumstance, especially we see this often in saliva, is that they can look completely normal one day and the next day they're sky high or through the floor. So just keep in mind that during perimenopause, during those changes, hormones are pretty unstable. So sometimes serial testing can be the way to go there. What cohorts should be used for ranges is another big question mark. There's a lot of different ways you can figure out what a range that's optimal, healthy, normal. There's a lot of different ways to try to approach that. There's population-based studies, which is very different from what is called a healthy questionnaire qualified study, right? Patient population is just how many people are coming in the door. And that's sick people, healthy people, we don't know. But you're going to get a large N number, and most likely you're going to have a fairly large reference range accordingly. That's where you end up with TSH reference ranges of, 10, 1 to 10 being a conventional TSH reference range, when we know optimal is way lower than that. So keep in mind just the importance of the reference range at the end of the day. So the last little thing to mention here is around urine testing, and the question about can urine testing be used to monitor BHRT. This is a hotly debated topic. Now, just take a step back and think urine, what is it? It is a filtrate of blood, right? So if there's any sort of truth to the notion that serum cannot be used to analyze bioidentical hormone replacement therapy, then certainly urine testing could not be used. So if you find blood unreliable when it comes to BHRT, you certainly would have to think urine was not useful either for BHRT. But what we're seeing here, if you look at this progesterone from day 1 to 42 on the same study, this is actually looking at the urine. And it says right here that the area under the curve, urinary pregnane 3 glucuronide concentration was not different compared to one from day 42. This was that study that looked at serum. So it did show up in the serum, and it didn't even show up in the urine. So that is a little bit of a wrench in there too. So when I think about urine testing, I think about not necessarily monitoring levels of circulating active hormone, but I think urine tells us about the children. It tells us about the metabolites. So progesterone turns into pregnadiol, ketosteroids from androgens, and then most importantly, I think, are the estrogen metabolites, right? Because we excrete them in the urine. So what do? Well, if somebody's on topical BHRT and urine hormone levels represent excreted levels, I would think that if those urine levels are robust, then you might have a concern about tissue saturation, right? You've got ample enough to circulate, and then you're detoxifying high levels of it out of the blood, and you're removing it from the system. But if levels are moderate or low, I'm thinking we don't know whether this is because of dose. It could be due to sluggish detoxification and elimination, right? So somebody could be having high levels, but they're just not detoxifying, so they're not removing it. It's certainly a big question mark in my mind. When it comes to method of urinary testing, 24-hour is always kind of the optimal gold standard, because it tends to help see the entire diurnal pattern of the hormone excretion. But if somebody's not on the hormones, you could think that first morning void is for the most part doable, but you are assuming to a certain extent. All right, what's good about urine testing? Well, really the valuable clinical insight around detoxification. Estrogen detoxification and risk assessment is a major boost for urine testing. And we're going to talk about this a little bit in the next session, but we think about estrone detoxification through three different pathways. So in phase one, we have three different things that estrone can make. We have this 2-hydroxy, which is potentially is seen as a safe metabolite, although it does have to be methylated. We have 16-hydroxy, which has estrogenic activity, but does have some benefits around protecting bone health and bone structure. And then lastly, 4-hydroxy is the one that we consider the ugly metabolite that does have a lot of clinical associations around hormone-mediated cancer risk. And glutathione conjugation is one of the things that helps to reduce any risk associated with these DNA addicts that come from this phase one metabolite. So here you can see that just in a pictographic representation of this 2, 16, and 4-hydroxy, what we sometimes call the good, the bad, and the ugly. So just a summary of urine hormones, I think they're a useful diagnostic tool. Their relevance in monitoring adequate levels of hormone, whether that's endogenous production or bioidentical therapy, is still a bit of a question mark around that. But it does help you provide specific data regarding methylation activity, risk assessment, and examining the role of stress on hormone metabolism for sure. So just keep that in mind. And also that the method of collection must be considered because it's not a linear process of how we excrete hormones throughout the day. So like at the end of the day, what do I do, right? This is kind of what we're talking about. So I would say that there's no perfect hormone evaluation. There's no single test for all circumstances. It's important to always think back to what I said at the beginning. What do I really want to know? Right? Am I trying to figure out why my patient's suffering from menopausal symptoms or andropause? Am I asking the question, is my BHRT therapy being metabolized in a healthy way? That's certainly more of a urine type of question around estrogen detox. Or am I trying to alter my patient's topical hormone dose? That might be an entirely different test that you would think about. And they require different approaches. But one of the things that we have available now, which I think is really exciting, is we have a capacity to look at really everything all in unison. We have a test that comes in one collection pack, and it looks at the HPA axis, it looks at the thyroid, it looks at sex hormones, and you can even pick within the sex hormone area. Do I want to look at salivary? Do I want to look at serum? Do I want to look at both? Do I want to look at urine as well? So there's so many options now to be able to get a much wider look at the overall hormone cascade and the symphony and the interplay. So I think when it comes to hormones, knowing as complicated as this system is, the wider the net that we can cast, the more we're going to figure out what exactly is the true root cause of this hormone dysfunction, and we'll be better targeted with our therapeutics. So that's mostly what I was here to talk about as it relates to understanding assessment and how that can lead to better interventions on the endocrine side. And I thank you very much for the opportunity to talk about this. Thank you to PLMI again, and thanks for your attention.
Hey everyone, my name is Dr. Jensky. I am a clinician at Richmond Integrative and Functional Medicine, and I am here to discuss the hormone hierarchy and how imbalances are often seen in just about every patient in my practice, and how this is becoming a pervasive issue that can best be addressed by looking more thoroughly at hormones from a top-down and sometimes bottom-up approach. So we're going to go into addressing root causes, seeing how there's clinical applications, and kind of building on some of the presentations that you've already seen. So let's get started and kind of see. So the objectives for this presentation are to kind of give an overview of endocrine dysfunction, discuss the interplay within the hormone cascade, and consider how things like thyroid dysfunction contributes to these hormone imbalances. And most importantly, looking at the hypothalamic pituitary adrenal axis and learning how to manage patients with cortisol dysregulation. So hormone imbalances, as I mentioned, are pretty pervasive. These are things that I see just about every day. I don't think I have very many patients that don't have some degree of hormone imbalances. some obviously worse than others. And the reality is that this is a growing trend due to many variables, but we'll get into some of those. Most of the chief complaints about thyroid and steroid or sex hormones are pretty common, but the adrenal cascade or HPA axis is often overlooked. And stress, I think, is just so pervasive and plays such a pivotal role in getting these right or them continuing to be wrong. And so paying attention to that is pretty important. The hormone pyramid kind of gives us an idea of how these hormones are balanced and influence each other. We also refer to it as the hierarchy. And as you can see, you can have a top-down or bottom-up approach, and metabolism and gut also play a role. And as we kind of correct these imbalances, you can see one start to autocorrect in another level of this pyramid, and that's the beauty of it. So for instance, if you have a person who's stressed out and has hypothalamic pituitary adrenal axis dysfunction and a little bit of a suboptimal thyroid history or some sex hormone related issues, and as you work on that stress, you see those get better without direct intervention. That is actually not uncommon to see, and that's why you have to kind of consider all variables when applying treatment options for patients. And so this is really the approach that we take, and this is why this test that we're going to be going over is so beautiful in the way that it's been constructed. So clinical applications, again, this is another kind of pictorial of the same of what we've been saying, and essentially we're looking at how the H or hypothalamus affects the pituitary that then affects these target endocrine organs, and they each individually produce their own hormone, and the hormones then exert their effects and then feed back up to say we need more, we need less. And so there's loops that are established, and you can find disconnects within these loops. And as you can see, some of the symptoms of hormone imbalances are incredibly common, but also incredibly vague, like fatigue or mood swings, but hair loss, hair thinning, change in libido, dry skin, sleep issues, appetite issues, memory issues, cold intolerance, digestive issues. I mean, just think about yourself or someone you know, how many of these symptoms that most people have and are caring about. And if there's a way to pinpoint them and relate them to a hormonal issue, it would make sense to go after that and see if they would improve. And I think that that's something that we can easily do. There is also, as I mentioned, the gut hormone connection. And this is probably not stated enough. I mean, the reality is that there is a hormone hierarchy, but gut plays a role in all of those aspects. And it's a major site of thyroid conversion from T4 to T3, which is to its more active form. It's how we eliminate the neutralized, detoxified version of these hormones. But it could also be how we recycle them and create imbalances. It helps balance cortisol. I mean, that's what the gut-brain axis is. It helps with nutrient absorption, which also helps with hormone production and regulation. So motility plays a role. I mean, there's so many facets to the gut being right or wrong that could influence these hormones. All right, so this is where the rubber meets the road, as we say, and we're going to do a case. And I'll walk you through the case to kind of show you systematically how each of these different aspects of that hierarchy influence this person's case and what we saw in her labs that then gave us insight based on the clinical presentation to be able to implement a plan. And then ultimately down the road, the goal would always be give it some time and reassess clinical correlation and then retest. The old mantra of functional medicine is test, don't guess. So we can then see what's better, what's the same, what's worse, and then pivot our plan accordingly. So this is a 44-year-old female, chief complaint of insomnia, low sex drive, mood swings, GI issues, relatively clean diet, fair amount of organic whole foods, but craves sugar, carbs, and occasionally overindulges, no medications, takes an over-the-counter multivitamin. She's an educator, moderate stress, mother of 2 children, and recently divorced. Sleeps about 6 hours a night and wakes up not feeling refreshed. A review of systems was positive for constipation, thin hair, low energy, and some heartburn. And although we have not discussed this test yet, this is kind of a classic Genova presentation of color coding where we're looking to see this kind of stoplight analogy. Is the way that I explain it to my patients is green is go, yellow is slow down, and red is stop. And there's some grayscale as well. And the gray and the green kind of clump together. And so if you're in the gray-green area, you're doing pretty okay. If you're in the yellow or red, then we probably need to intervene and maybe dive deeper. And so this is clearly pointing out that the adrenals are a big issue, a little bit of a thyroid issue, a little bit of a sex hormone issue, maybe a little bit of a detox issue. But we're starting to see some data points, and that's nice. And as we dive deeper, we can see where we can actually intervene. So HPA axis, again, I mean, I know there's redundancy here, but you can't be redundant enough when you're talking about stress and how it affects health. It is pervasive, meaning just about everybody has it, and it's not going to go away. I mean, that's not to be defeatist or depressing, but stress is a part of life, and it's how you handle that stress, how you identify it, whether or not you're able to pick up on early stressors as they're giving you subtle clues, or are you waiting for the body to scream at you and say that you're stressed out? So listening to the whispers before you hear the screams, as I say to my patients, is always important. And when you're talking about stress, this is psychological stress, emotional stress, physical stress, sometimes physiologic stress, where I have patients that don't feel stressed out, but like, for instance, don't feel anxious and don't feel like they're overwhelmed, but their body is screaming. And when we look at these loops and see that they're off, you know, sometimes that's the data that we weren't expecting to see, but it allows us to move forward and find a way to intervene and get their health better. So this is how it's regulated. Essentially, the hypothalamus is releasing something that then tells the pituitary to release something that then tells the adrenal gland to make some cortisol or not, or others. And then that feeds back up either negatively or positively to say we need more or we need less. So this is an example of a 24-hour salivary cortisol curve. And as you can see, the green is where we want to be. And the most important part of this curve is essentially the shape or morphology of it. And you're looking for that kind of lazy L appearance. And if you start to lose that shape, you start to see flattening, whether it be flat and high or flat and low. The data supports that all-cause mortality goes up, and that's a big deal. And what that really means is that every chronic disease state is getting a little bit worse if you start to see that, and that person is probably progressing in their dysfunction. And so the goal is to get within the green or yellow area and then define where there might be a deviation and try to explain why that might be happening so that you can then intervene, whether it be a blood sugar regulation issue, or I need to work on sleep hygiene, or start my day off on the right foot, or layer in adaptogens throughout the day, or just nutritional support, or whatever the case may be. This gives that insight. So then we start to see that there's a balance, and this scale is clearly tipped in one direction, and it's the difference between anabolic or catabolic balance. And so it's basically, are we building or are we breaking? And sometimes we want to build and sometimes we want to break, but mostly we want balance. So another aspect of the HPA axis is something called the cortisol awakening response. And that is this physiologic response to awakening. It's unrelated to the cortisol secretion throughout the rest of the day. And it's really more of a reflection of the suprachiasmatic nucleus being activated by light first thing in the morning. So it's kind of like our central biological clock. And it gives an indicator of overall resiliency. And so you can measure these on the same salivary test, and if it's blunted, that's bad news, and that person may need more support. So it gives more insight above and beyond what you would typically see on the adrenal stress profile. But as we mentioned, this is one of these things that's going to change over time, and it's going to be influenced by many parameters. The other thing that's measured is DHEA, which kind of acts as the counterbalance. The best way that I explain it to patients, and we'll see on this one, is essentially if you have a stressor, it's going to cause you to release catecholamines like adrenaline, and that's the gas. And cortisol actually acts as the brakes. So cortisol is protective and beneficial, and without cortisol, within 7 to 10 days, you would die. And so the reality is that we need cortisol, but it's about Goldilocks, right? We want it just right, not too much, not too little. And when you're releasing adrenaline, subsequently releasing cortisol, what you're doing is allowing that person to survive that stressor. So fight, flight, freeze to live another day. And ultimately that cortisol will then find its balance and go back to the mean. And we have resiliency and we've grown. And so that could be even a hormetic stressor. The net gain is that we get better and stronger as a human entity, versus something that's a stressor and a negative connotation. And so when you start to have excess catecholamine, so I'm running from the tiger, I'm stressed all the time, that excess adrenaline leads to more cortisol needing to be released, and we wind up with cortisol receptor resistance. So the brake pads are wearing thin, we don't apply the brakes like we did, we need even more cortisol to get the same effect, and now we go from protective to problematic. And DHEA will respond in a way where DHEA will go up, and that DHEA then acts as a counter-regulation or balance to protect the brain and other tissue from excess cortisol production while that person is trying to work out whatever stressor they may or may not be dealing with. And the reality is that doesn't get addressed, that will continue on, and DHEA will eventually peter out as you only make a finite amount. And then eventually cortisol gets shut down because the body's literally trying to protect the brain from that excess cortisol that no longer has that counter-regulation. So there are steps to this, and there are points of intervention all along the way, but the goal is to see where that person is and then meet them there. And when you look at this result, the CAR is a little bit elevated, so that could be an adaptive anticipation of daily stressor. So this person's waking up already stressed out about their day. Cortisol being elevated between 3 to 5 p.m. Sometimes that could be glycemic control, so their blood sugar is dysregulated. Considerations would be exercise or blood sugar regulation in whatever way you'd find that appropriate, whether it be dietary changes or, is it stress induced? So I want to work on some meditation or adaptogens, or do I need to add chromium or cinnamon to this person's diet? Lifestyle stressors, pain, these are all things that can affect it. The DHEA being low is usually due to things like chronic stress, but I can see it in advanced aging, the HPA axis dysfunction, again, chronic stress. And that's going to lend itself to things like immune dysregulation, cardiovascular disease, arthritis, osteoporosis. I mean, these are all bad words, basically. And so someone like this who's only 44, we know this is not advanced aging. This is someone who has been chronically stressed and maybe acutely on top of the chronic, and it's problematic. DHEA is as low as it is. So that then causes the DHEA cortisol ratio to be low, which favors catabolic activity or breaking down, not building. And so this person is breaking down, maybe quite literally. So then we look at thyroid metabolic impact, and we're looking at, again, that HP, whatever tissue organ it is. And so hypothalamic pituitary thyroidal axis. And the communication between the pituitary and the thyroid is a test that most people are familiar with called TSH. And the way that I describe this is if the TSH is high, the pituitary is screaming at the thyroid to make more hormone. So that's a hypothyroid presentation. If the pituitary is saying, hey, we got enough, then the TSH is typically normal or low, at which point in time you can say that the person is euthyroid or maybe even hyperthyroid. So they're starting to whisper or break that communication. The thyroid then should be making thyroid hormone if it can, if it's not been destroyed by autoimmunity or toxins or whatever else, or removed because of surgery. And you wind up with T4 and some T3, and then out in the target tissue, gut as well, we get conversion from T4 to T3, which is taking one iodine and removing it. So that is done by an enzyme called deiodinase that allows us to have this more biologically active form of thyroid hormone called T3 that then needs to get into the target tissues and exert its function, feed back up. We need more, we need less. So in this individual, the TSH was considered to be high normal, and I don't know if any of you have had your thyroid measured, and if you've done so, it's usually done through a typical lab like Quest or LabCorp, and as you can see, this range is actually much tighter than the typical range, which goes, I believe, all the way up to 4.5. So the reason being is that the range is too big, and this is the more appropriate range. Less than 2.5 is the goal, and for autoimmune patients, I like to keep it as close to 1 as possible. And so this being at 2.29 by general standards would be considered very good. By our standards, is considered high normal, and therefore maybe some early hypothyroidism. Iodine imbalance could be a role, and we'll talk about nutrients because they're vastly important when it comes to thyroid function. In addition, the reverse T3 in this patient was high, and so you can see that with things like iron deficiency, toxins, liver disease, aging, fasting, infection, inflammation. I would say inflammation and stress are probably the two biggest reasons that I see this elevated. And as you work on that, it tends to autocorrect on its own. I mean, it's a built-in mechanism to keep us alive. I mean, reverse T3 basically takes T3, the most biologically active form of the hormone, and flips it into reverse T3, which is inactive. And that's so that if you're lost in the desert, you can survive, rev your metabolism down, and try to find a food source, and then convert back. Most of my patients are not starving. If anything, they're overfed. And so this is typically something related to infection, inflammation, stress. But you can see it with these other reasons as well. And that's going to clearly affect your T3 levels. And so in this case, we see that free T4 looks pretty good. Free T3 looks pretty good. I also measure total and total T4 and total T3. And in this case, we don't see any evidence of autoimmunity. So again, we're starting to kind of put these puzzle pieces together, and we see how this regulation occurs. But there's, as we're going to see, all these points of function or dysfunction along the way related to nutrients like iron, iodine, magnesium, B vitamins, selenium, zinc, vitamin D, vitamin A, etc. Here we go. So important nutrients and thyroid metabolism disruptors. So iodine to produce hormone, selenium and zinc, really important as cofactors for that deiodinase. So really important to get T4 to T3. You need zinc, you need selenium. Iron, tyrosine to form thyroid hormone, fat-soluble vitamins, so D and A in particular. The others would be E and K, but in this case, D and A are how thyroid hormone gets into the cell. So say you have adequate hormone measured and the TSH loop shows you that that feedback loop is functioning appropriately, but the patient still exhibits clinical symptoms of hypothyroidism and their D comes back at 16, it may be that they're just not getting thyroid into the cell. We just need to work on getting their D levels to a therapeutic level. Some disruptors of this would be toxin, stress, fasting, overeating, as I mentioned, and a growing list of medications. All right, on to sex hormones. So this is the steroidogenic pathway. It's a pretty famous slide, quite busy, but really important. We're not going to go through all the details, but the take home is that all of this starts with cholesterol. And so cholesterol, which has been demonized, is not as bad as you think and is quite necessary for an incredible amount of biological functions. In particular, in this case, all of these hormones. Without cholesterol, you can't make these. So cholesterol becoming pregnenolone, which then can become progesterone or start to work its way over to sex hormones, and through androgens make estrogens, or work its way down to mineralocorticoids like aldosterone to regulate salt and water balance, or work its way down to cortisol for stress management. And you can see that there's all kinds of feedback loops and inhibitors and inducers and all of these different variables that play a role. So it's quite complicated, but if you're able to measure this and see green, 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 and then all of a sudden yellow, red, then you know where there might be an area of you can intervene and therefore get that person better. So where there is a disconnect in the loop is often very, very telling clinically for this individual, and that's why testing is so important and appropriate testing at that. So speaking of the devil, so this is really probably one of, if not the most important slide that we're going to go through. And the reason being is that it really kind of takes home or hammers home the point of this Endo Plus test, which is to have all of these different compartments being tested in one. And so it's thinking through transport is what we like to say. And what we're looking at is endogenous and exogenous, or made versus taken. And when we're looking at those in totality, we then have to consider things like blood and lymphatics, and then bound versus unbound, so available versus unavailable, processing by the kidneys and the liver if functioning appropriately and supported nutritionally, and then excretion and elimination. And these are all really important things to look at to give you the best clinical total picture. And so, for instance, when we look at things like blood, it's representative of total, so bound and unbound, versus saliva, which is just unbound. So we're seeing bioavailability versus maybe just what's there, but not necessarily what's bioavailable. When you look at urine, you're seeing metabolites, and the metabolites are going to tell you what's going on with their detoxification, which is always important. And so you can also see why there's benefits to each of these and why there are limitations as well. And so the key is, if you're collecting all this data together, you can look at that person's case and say, hey, this individual has enough in their serum, but not enough in their saliva, and their detox isn't good, so we're going to do X, Y, and Z, or vice versa. And that's really helpful versus just looking at blood and saying, I think this is what's going on, but I'm not sure. And then you're kind of trying to reinvent the wheel or chasing your tail, and without the other data points, you can't ever really figure it out. And this is a lot of clinical correlation and trial and error, and patients get frustrated. And so the best thing to do is to just have that data all at once. Now, you can do this broken out. You can get just a urine 24-hour essential estrogens test, which I do often. You can get a one-day hormone kit or menopause kit or menopause plus kit, all Genova tests, which I do often, and then order serum through Quest, LabCorp, whatever, or you can get the Endo Plus kit and have all that in one spot, which is pretty incredible. So again, this kind of goes back to the feedback. Again, this is a little bit redundant, but it just hammers home the importance of all of this and kind of that this is a top-down approach, just like the hierarchy. I mean, essentially, it's the brain telling the pituitary to tell the target organ to make something and then do its job and then go back up and say, we're good or we're not. So sex hormones. This is the most difficult part, I think, to manage because for a variety of reasons, and this is one of them, is that they're going to fluctuate, and they rapidly fluctuate from day to day. And if you have a perimenopausal patient, and that's when the fluctuation is occurring, then that may actually go on for years. Most perimenopausal women are in perimenopause for a period of time. It's not like this transition happens, over the course of 6 months to a year. I mean, for some it might, but it could be up to 3, 5, 7 years for others. And so it tends to be a little bit of a moving target, hence the need for proper testing and clinical correlation and therapeutic trials and clinical correlation. And the reality is the more data you have, the better off you're going to be at managing that patient. But that's why things like saliva and serum and urine play a role and are important, so that you can see about these fluctuations and see about what needs to be done. So back to the case. So this is serum, just to be sure. Okay, so right there, serum. So this is the blood, and we see that the progesterone is actually on the low-ish end. It's not low per se, but it's low-ish. And so what can cause low progesterone in this patient? Alcohol, obesity, thyroid disease, menopause, low cholesterol, again, that precursor. Maybe they're taking hormones that are affecting the progesterone. So options, if this is a weight issue, lose weight, reduce alcohol, exercise more, you can use botanicals, you can do bioidentical hormone replacement with oral micronized or transdermal progesterone. We see that estradiol or E2 is low in this patient. So what can cause that? Menopause, thyroid, stress, obesity, aromatase inhibitors, which block the conversion of testosterone into estrogen, excessive exercise, so overtraining, underweight. So here are some of the options that we can do there too. The DHEA-S looks okay. So this is serum. We saw saliva. It wasn't great. So again, you're seeing a discrepancy, and it's important to kind of look at all of that and determine what's best for this patient. Testosterone in this case, serum looks okay, although is that optimal? I don't know. We would have to clinically correlate and see if this person would need more testosterone, because this is a range and everybody's different, and normal is not optimal. Estrone looks to be okay. Sex hormone binding globulin looks to be in the low range of normal. So perhaps this is not an issue of bound versus unbound. And then estriol is low. Back to the case again. So FSH and LH, part of that pituitary communication with these target organs, suggests that this person is premenopausal. So this is not a menopausal issue. So this is either peri or pre, and this individual has labs that kind of give us some insight there. And the IgA, prolactin, androstenedione, LH, and FSH all give us more insight as to where this person might be in her season of life, that allows us to better understand why the progesterone, estrogens, et cetera, look the way they do, so that we can intervene, but also gives us ideas of what to expect moving forward. Because if it's postmenopausal, then you're usually kind of in a fixed state where those numbers that you're seeing aren't going to budge much until you do something about it, versus peri, when we mentioned it, and you may have to move along with that patient, whether that be dosing or ways in which you're delivering that hormone replacement therapy or whatever else you're doing. So progesterone, this is saliva to be specific, so different than serum. And so this is, again, unbound, bioavailable, what's in the tissue. And this person who had low-ish in serum is high in saliva. So again, really important data. We also see the DHEA being low again in saliva, and we see testosterone being relatively low in saliva. So again, looking at different compartments, incredibly important for all these reasons. And this is just one case, but it's kind of hammering home that point. So why would the progesterone in saliva be high when in serum it's lowish? Gingivitis, pregnancy, stress, smoking, caffeine. So here are some options. When the DHEA and the testosterone are low-ish or low, again, going back to chronic stress and what we can do about it, adding DHEA, managing stress, maybe adding testosterone, maybe working on strength training, making sure this patient's getting enough protein in their diet, enough zinc in their diet. Estriol, which we previously had discussed, we see is a little bit high, although in the serum it was on the lower end. So obesity, hormone replacement, is this person on estriol? Detox issues, endocrine disrupting chemicals, again, other things that can contribute to it. Melatonin, this slide is more so kind of along with the stress loop axis and what can be going on there, but it shows, if you recall, that that person had a little bit of an elevation in their cortisol around dinner time, and that they had an over-exaggerated cortisol awakening response and low DHEA, so a dysfunctional HPA axis, chronic stress. And we see that melatonin in the morning is high, and we see melatonin when it should be highest at night is low. So this is flipped to what we would want. And that could be because of things like supplementation. Is this person taking melatonin? Is this person have diet issues or slow metabolism, caffeine, exercise? And low at night, are they staring at a screen all night and exposing themselves to lights or EMF or stimulants that are going to suppress their melatonin? Not only is this going to affect circadian rhythms, melatonin and cortisol, but it's going to affect inflammation, it's going to affect gut, it's going to affect immunity, it affects polarization of the adaptive immune system. Melatonin is going to push a Th1 response, which helps us fight and clean out infections. And cortisol is going to push a Th2 response, which helps deal with things like allergens, but also resolution of infection and inflammation. And so without that circadian balance, then you might have persistence of infection or persistence of inflammation or lack of resolution. And that then lends itself to other problems. So we start to go beyond hormones to see the immunological manifestations that could occur. Sex detox. I mean, this is about as important as it gets. I don't know why this isn't standard of care. I think the data supports that it should be. I mean, the reality is that cancer rates are on the rise, colorectal cancer, but obviously in this, and for the sake that we're talking about, estrogenic cancers and hormonally related cancers. And so why not measure on a very basic urinary test someone's detox capacity? And what we're looking for is the breakdown of estrone. I mean, there's three types of estrogen. There's E1, E2, and E3. E1 is estrone, E2 is estradiol, and E3 is estriol. Estradiol is the predominant estrogen of a cycling female. Estriol is the predominant estrogen of a pregnant female, and estrone is the predominant estrogen of a postmenopausal female. And the reality is that at any given time, all of these are being made. And at any given time, they can be balanced or imbalanced. And then ultimately, the fate of all of them is that it comes down to estrone. And estrone is problematic because if the wrong type is made, then you can lead to what are called DNA adducts or quinones that can definitely lead to cancers down the road. So we used to call this the good, the bad, and the ugly. We now know that the 16-hydroxy is not as bad as we thought. A little bit goes a long way, meaning that it's bone protective and we want some. So I now refer to this as the good, the slightly less good, and the ugly. So we want all of it or most of it to go to the 2, and then we want that to be methylated for neutralization, and that's through a gene called COMT, which a lot of people have SNPs in or typos in. This is a methylation gene that kind of is akin to things like MTHFR and others. And then we want some 16, like I mentioned, and that gets converted into estriol. And then we want none of the 4 if possible. And if we are making some, we at least want it to be methylated into the 4-methyl or neutralized by glutathione, which is not is not in this pictorial. And so, for instance, each of these is an enzyme. And unlike the methylation enzymes, if you have a SNP or typo in one of these genetically, which can be measured, then these are upregulated and they're going to get pushed down faster. And if you have a SNP or typo in the COMT, then it's downregulated or this is going to work slower. So a bad scenario for someone would be if they have a CYP1B1 SNP and a COMT SNP, because they're going to funnel down this pathway quicker and then they're not going to methylate it. And if you add in that they have issues with glutathione transferase or recycling, or they don't have enough glutathione, then this is a ticking time bomb of an estrogenic cancer down the road. And so you want to enact change by evaluating this in a patient and then seeing what you can do about it. Can we push down this pathway? Yes. How? Broccoli, cruciferous vegetables, certain supplements to get down this pathway. In addition, how do we work on methylation? Supporting it, B vitamins, magnesium, SAMe, other methyl donors, determining if this person's genetics are consistent with this, measuring other surrogate methylation markers like homocysteine and methylmalonic acid, measuring their B vitamins, measuring their magnesium. I mean, the reality is most of the stuff that you need to figure out what's going on can be tested or measured, so why not do it? This pathway and this pathway get upregulated, the ones that we don't necessarily want, by things like smoking, so don't smoke, by alcohol, so don't drink or drink less, by being overweight or being inflamed, so you work on that. And then they're also upregulated by xenoestrogens. So if you detoxify that person's environment, now perhaps we see a shift towards the better pathway, and you're making that person better just by what I like to refer to addition by subtraction. In addition, you can block both these enzymes with things like resveratrol. So there's so many points of intervention here. So in this individual that we're talking about, we see that the 2-hydroxy E1 and E2 is low. And so that's significant for maybe low parent hormones, meaning not enough estrogen, decreased metabolism or excretion, upregulation of the CYP1B1. So just to go back, upregulation of this pathway, perhaps they have a SNP there. Maybe they're having aromatase inhibition, but here are the options: broccoli and cruciferous vegetables, soy, flax, catechins from green tea, or you can take EGCG, resveratrol, lose weight, indole 3-carbinol or DIM or sulforaphanes, all that come from broccoli. Measure oxidative stress, maybe give glutathione. So there's a lot that can be done here, and this is a very basic, easy test that can convey information about someone's risk that you then just change a few things and it gets better, and you've theoretically decreased their cancer risk moving down the road, which is a huge deal in my opinion. Yeah, so I talked about this in the beginning, huge gut, phase 1, phase 2 from liver to gut, which is phase 3 or excretion. Let's just quickly talk about phase 1, phase 2. So phase 1 is how the body takes something that's already toxic and through these processes converts it into something that's a little bit more toxic, or what we call a reactive intermediary. And that reactive intermediary then has to be neutralized by phase 2 to then be excreted through stool or kidneys. So pee or poop it out, essentially. And so phase 1 is a lot of the cytochrome P450 enzymes, heavily dependent on things like vitamins, minerals, antioxidants. Phase 2 tends to be things like methylation, sulfation, glucuronidation, glutathione conjugation, amino acid conjugation. So does this person need methylation support? Do they need sulfur donors like cruciferous vegetables? Do they need to work on glucuronidation, citrus? Do they need glutathione? Just give it to them. Do they need, more protein for amino acids? And then this is where diet comes in, and then working on the gut to really play a role in making sure that once the liver's done all this heavy lifting, that it's just getting kicked out and not recycled back in, which is where this comes in. So beta-glucuronidase is something that we can measure. It's measurable on a stool test, and it basically shows you that if this is high, that person has a microbiome imbalance that is causing an upregulation in this enzyme that is taking whatever work the liver did and causing them to do it twice. So basically the liver is converting phase 1 to phase 2, neutralize, get it out, and when it gets to the gut, the neutralizing component gets cleaved off, and then this is enterohepatically recycled or recirculated back to the liver to do the job twice. And so you can use things like calcium D-glucarate to block or inhibit this enzyme from that happening, so that that person is getting these hormones that have been neutralized out and not giving the liver so much work and contributing to the overall toxic burden in their system, not to mention depletion of resources and increased risk of other things like cancers, especially hormonally related ones, which there are human studies associated with that. So this is the point of intervention as well, but really the big take-home message is that the gut plays a big role in all this. There's a specific branch of the microbiome called the estrobolome that's job is to get rid of estrogen. So you got to make sure the person's gut is right. This goes back to what I was just talking about with phase 1, phase 2. So phase 1, B vitamins, glutathione, cruciferous vegetables, some other fun things, vitamins, antioxidants, minerals. So really, if you look at this list, like put this person on a good multivitamin and make sure they eat clean with a lot of broccoli and you're covering it all. Phase 2, amino acids, get enough protein. Methylation, they're on the multi or methylation support. Cruciferous vegetables we already talked about, and then ellagic acid from pomegranate and berries, catechins, watercress, prunes, glutathione. If you're looking at the overlap with all of these, if you give someone a multi, some glutathione or its precursors, and they're getting enough cruciferous vegetables and protein in the diet, you're basically covering all this. But you can pick and choose, and you can see where someone is inherently weak and get very, very specific, and that's awesome too. But the reality is that you can use broad strokes as well. And then phase 3 is elimination. So this is the kit that I was talking about. It's called the Endo Plus kit. It is the most comprehensive hormone evaluation available right now that I am aware of. The turnaround time here, the instructions that come with it are very basic and straightforward. Genova's great about walking you through it if you need assistance, but it's going to give you all of these data points that we just went through. You're going to see this person's thyroid function. You're going to see this person's HPA axis and their melatonin curve and their cortisol awakening response. You're going to see their detox for estrogens. You're going to see their hormones, sex hormones, whether or not they have issues with bound versus unbound and what to do about it. And then if you want to also add nutrient testing through your local lab, do so. But it's giving you a great foundational starting point to build on and at least tell the patient, this is the why behind all those symptoms that you have, and this is what we're going to do about it. So unrivaled comprehensive evaluation, most thorough hormone assessment available, building a personalized profile for each patient. As you can see, you get your overview, it's color-coded, it's basic, it tells you where you're weak, dynamic reporting, easy solutions, even gives you the answers to the questions on the test right here, basically. And it's cost-effective in this way that you can break it down. You don't have to do the whole thing. Say you already did thyroid on someone through Quest and it's covered by their insurance and they don't want to pay for that. Great, don't. And just do every other aspect of this, but then you're still getting everything else under one test. Or as you build, say this person seems stressed and I want to do an adrenal stress profile on them, but I don't know about their thyroid and I think they might have a sex hormone issue. The more you add, the less this test costs, because if you're doing these things individually, like I mentioned, collectively it's going to cost more than doing all of it under one test. So if you do a 24-hour urine essential estrogens and you do a menopause plus kit and you do this and you do that, collectively is going to give you the same data, but it's going to cost more money. You just do this one kit and it's going to give you everything. So I know that I talk fast and I know that that was a lot. Hopefully it gave you a lot of good take-home points and gave you some information that you may not have known or had and where you can intervene with patients, or at least if you're just starting out, where you can start. I mean, it may seem complicated, but the more you do these, the more you're going to understand them, the better off you're going to be at them. And really the best way to do it is just get your feet wet, get in and start working with patients and see where there's a disconnect and do something about it and see how it clinically correlates and then ultimately retest it to show them that they've improved. And that's the best part about it. But I highly recommend this kit. I highly recommend Genova's products in general. I think they're great. This is what I use in my practice. I see hormone patients all the time and they get better and they feel great. And it's not rocket science. You just have to understand it and you have to just keep learning and evolving with it. But I think that's the reality of all this. So I hope you learned something. I hope you had a good time, and I will maybe see you again sometime. Take care.
Well, here we are at that portion of our personalized lifestyle medicine education programs that, for me, I find the most exciting because it's kind of an opportunity to have a repartee conversation with our opinion leaders. And of course, we're very fortunate to have two remarkable opinion leaders. You've already heard them with their presentations earlier, Dr. Michael Chapman, who will talk more about his background expertise, but how it applies to this topic, and Dr. Christian Jinsky, who is, the two of them really done incredible work in kind of making a very complex topic accessible. So I want to compliment the two of you as we move into our discussion collaboratively. As you remember, as viewers of this program, participants, this is jointly sponsored with Genova, and we thank Genova for their years of support of Personalized Lifestyle Medicine Institute. And I think this program is right in the sweet spot, obviously, of Genova's expertise over the years. The Endocrine Symphony, evaluating and supporting the organs of communication. I mean, there is a really, we could go on for weeks with that title. That takes us in all sorts of new and uncharted areas. But I think my two colleagues have done a really good job of kind of setting the tone for focus in this area. And you know, what I tried to do in my introductory comments to begin this program was to really talk about what we mean by communication, because I think that's a topic that requires its own kind of understanding, because I think there's this belief that we communicate verbally, and we have these sound waves that impact upon our tympanic membranes that give rise to sensory responses. Well, that's one form of communication, but there are many forms of intracellular communication that occur through various types of molecular species that interface with the nervous system and the immune system. And that then creates this endocrine symphony that is interacting across many players around our body, both autocrine, paracrine types of signaling. And so the term communication really refers, in the way that we're using it in this program, to signals, that the signals are things that we get from the outside and inside world, like from our microbiome, that then signal to receptors that then transduce themselves into functional changes within cells that are part of the way that cells communicate in tissues, the tissues to organs, organ systems to the whole body, and how we're in interaction with the outside world. So with that, we have people coming into healthcare providers' offices, and somehow their communication system is not completely copacetic because it's telling them that something's going wrong. And, you know, fortunately, we got pretty good alarm systems in our body that tell us when all is not properly aligned. And it's those symptoms that are related to this kind of dysfunctional communication that's been the focus of this program. So with that as a long-winded introduction, I apologize for the verbosity here. Let me just throw out the first question to get our conversation started, Michael and Christian, and that is, when you look at your years now of service and experience as to first level things that clinicians who move into this field of functional integrative, the kind of systems biology, healthcare, what are the first things as it relates to the organs of communication, their assessment, that would be the starting point for people getting involved in this field? And Michael, I'll start with you.
Okay. Yeah. I mean, I always tend to think of going, I think when a lot of people start getting into functional medicine and are new to this field, whether it's they're digging into the GI tract or they're digging into hormones, I think we tend to find a tool or we find a therapy, and then we kind of start there. And I always like to try to press upon the importance of really finding the model that works, because if you tend to understand how the system works globally, then as you start to integrate more and more of these tools, and as science changes and as therapies change, you are just reworking your tool a little bit. And so I think a lot of what I've tried to communicate in the presentation was, you know, what's the appropriate model, because it is such a complicated system, but all of these systems are complicated, are they not? The GI tract, back, nutrition, all of these things are really, really complicated. So if you start with a really solid foundational model, then that helps you, I think, quicken your learning, because really you're just plugging and placing things as they come up, and you're not having to do a lot of rework or unlearning. And so I think I would say for clinicians coming into the field, it's like really understand how all these things interrelate, but they interrelate in a way that actually kind of makes a lot of sense. And once you have that model really strong, then it makes everything else a lot easier when you're learning.
Thank you. Christian, how about you? What's your perspective on getting started down the road?
Yeah, I would agree. I mean, I think ultimately, whether you're talking about hormones or detox or autoimmunity or mood, you always have to reference the gut. And so that's why in part of the presentation, the gut was referenced. And that's a good starting point. It's always, when in doubt, heal the gut, go after the gut. And because it's going to affect communication in many ways beyond just the loops of these different endocrine systems. But the reality is I agree with Michael, is that you have to find some tests plural, that you're comfortable with. And as you order more of them, whether it's experimentation on yourself and family or actually seeing patients, you'll get comfortable with how to read and interpret them, and then the nuances of implementation of treatment strategies. And so it's really starting to get that baseline established understanding of the system of systems, as you mentioned, understanding how the gut also plays a role, starting to piece together the hormone hierarchy and how it's layered, and understanding how each loop itself is influencing parts of that loop in a functional or dysfunctional way, but then the bigger loop of the pyramid, how it all kind of interweaves. And it seems complicated, and it is, but as you kind of plug in and go through, it becomes more and more simplified, and you start to see patterns, and you start to see the same things over and over again, and the same treatments seem to work. And as personalized as it gets, there's still things that are going to work for most people. And as you start to kind of layer those and you can get more specific with the individual, I think it just becomes a little bit more linear than you would think it might be.
Yeah, thank you. I think you both gave some really great kind of overview as to the strategy. I'm reminded as I'm listening to you, and because of my length of time in this field, I'm going to sound like the old soul here. But when I go back to the start of the progenitor of Genova, which was the Great Smokies Diagnostic Lab, and Dr. Stephen Berry and Dr. Marty Lee being the founders of that organization, their concept was really born out of things that Stephen had learned when he was at the Ambassador University doing his naturopathic degree, and he did an intern residency with a very esteemed medical doctor that was in the integrative nutrition space, Jonathan Wright. And in that laboratory that was actually a companion lab to Dr. Wright's clinic, the lab director, actually, that lab was one of my former employees in the lab that we had in the 70s that was starting to develop these microbiological tests on a very crude level for the gut function. And that then gave birth with Dr. Berry and Dr. Lee into the comprehensive digestive stool analysis. And the construct that you could actually measure something in stool that was going to be related to the functional health of the individual in traditional medicine was quite a remarkable, kind of frame-shifting concept. But from that then was born the recognition that in that stool is lots of information and information about the enteric nervous system, the enteric immune system, inflammatory mediators, and then we start getting into things like calprotectin and all sorts of interesting elastin and other kinds of variables that give us more interrogation of the system. So when a person starts into this field, it may, as you said, be a little bit daunting. So how did we make simplexity out of this? Because I know Great Smokies is later to become the more refined Genova has done a really good job of taking these complex concepts and making them more simple to be understood and applied. So I call that simplexity. How would you see that happening with regard to the products and services that Genova now provide?
Yeah, I would say it really actually piggybacks on the point that Dr. Jensky was making, where I think it's a matter of pattern recognition to a certain extent, because when the more data points that you have, and certainly around the microbiome and stool testing, like you mentioned, Dr. Bland, there's invariable number of different data points that we could be looking for and that are coming out and that we're discovering on a regular basis. So the data analysis and the pattern recognition portion of it is where I think everything needs to come and create that simplicity. Because at the end of the day, we're talking about like key dysfunctional things that occur. So that could be something like inflammation, and really if you are understanding which of these biomarkers or which of these dysbiotic patterns or what have you contribute to inflammation, you can start to bucket everything down into kind of that key evaluation of inflammation. Another one would be something like immune dysregulation. I think about as it relates to the GI tract, another key function of the GI tract is digestion and absorption. So, there's kind of these major concepts, and we're just adding data points to get refined analysis into those key dysfunctions. And I think the same thing can be said for any of these major systems, whether it's the endocrine system, the neuroendocrine system. There's sort of these major key dysfunctions that occur. And so as long as we can get more and more accurate and more even preventative data points, but we just have to keep that model and understand at the end of the day, these are kind of general key dysfunctions, and we're just getting better at detecting them earlier.
Yeah, I
Dr.
would
Jensen?
agree. And I love that term simplicity. I'm going to steal that, by the way. It's going to be spread all over Richmond for the next few years. It's perfect. I mean, it explains exactly what we're talking about. I mean, the reality is that these are complex concepts, but the more and more you learn them, the more and more you boil it down, the more and more you apply it, the simpler they get, hence simplicity. And Genova has been, as long as I've been practicing integrative functional medicine, has been literally right at my side all along the way. And that's part of the reason why I use their tests and love them as much as I do, is because they were there to kind of guide me. And you learn the data, you're taught when you're in your fellowship, this is what it means, and this is what you should do about it, but that's different than going and applying it. And so you order these tests, and they're really great about setting up physician consultant meetings to kind of walk you through, this is what it means, what are you struggling with, this is what I would suggest. So there's a lot of handholding if necessary, so it becomes less and less daunting and makes it more comfortable for you, because the reality is everybody's on the same team. The goal is to get patients better, and if their products are being used in that way to help patient care, of course they're going to facilitate that. There's also tons of resources on the website as well. And so you just really have to start to recognize some of the patterns and then intervene. And what I tell patients all the time is essentially every time I see an abnormal result, there's two thoughts, and they're not necessarily divergent, but two thoughts that go through my head. And the first is, what are we going to do about this? And the second is, how did this come to be? And so if you boil it down to that, then you can intervene. And while playing detective, that patient might start getting better. Like, for instance, going back to the inflammation example, if there's a fire in your belly, let's put it out, but who started it? And let's figure that out and start to kind of get to that. And that then becomes the combination of, I'm working on your system in the now, but we're also aiming towards root causality and ultimately determining how you got here and giving you the tools to live the rest of your life and prevent it from happening potentially, whether it's addition by subtraction or managing stress better or whatever the case may be. But I think if you're looking at it through that lens, all the data points, which are ever changing, whenever you start to feel comfortable, there's new stuff that's coming out. I mean, that's the beauty and the conundrum of this. But I think really it becomes simpler if you look at it through that lens.
Yeah, I think you both, those are really good salient news to use concepts, is to try to keep distilling down, the whole thing of Occam's razor. You try to get down to a central point that can kind of pull together multiple variables into a single, maybe hypothesis, but at least it's something as a working hypothesis. One of the questions that I often get about the use of laboratory in the assessment of chronic health problems is, are all these tests separate one from the other? So like if you do hormone analysis, is that separate from a microbiome analysis? Is that separate from a nutritional NutriVal? Is that separate from an inflammation assessment? And what I try to point out, and I'd like to get your comments on this, is that, for instance, hormones are directly interwoven in this web with GI immune function, with the microbiome, with hepatic detoxification into first and second stage metabolites and excretion. So maybe you could give some color as to how you see hormones interrelated in the broader picture. So we're not looking at kind of endocrinology standing alone by itself over in the corner.
Yeah, that's a great question, and I think the quick answer is everything's connected. Everything in the system is connected, and so all of these different tests are giving you a little bit of a different shade. It's giving you a little bit of a different lens to look into what piece of the puzzle might be studied, but you always have to understand how interrelated all of these functions are. Nutrition related to GI, related to endocrine. And so specifically around endocrine, I think the particular lens that I use to view it is because it is kind of the system of communication. I almost think of it more as that it gives you that information into how either the external world is having some sort of impact on the hormones and the communication system. Partly because when I think about HPA axis function, when I think about thyroid, I almost think more these days about neuroendocrine and not separating the two, because it's about how your expectations and whatever's happening outside of you is having some sort of impact inside of you. And that can even be, just your perception about a certain event. It doesn't have to be, a traffic accident or something that happened to you. So I think there's that neuroendocrine component that really is unveiled based on some of the endocrine testing that goes in there. And then the other component is energy management is another huge thing that we're thinking about with respect to specific to the endocrine system, and whether that's the balance between insulin resistance and insulin sensitivity, whether that's how the HPA axis function is impacting thyroid mechanics, right? And so it's sort of, to me, a little bit more specific in those areas, but yes, definitely we think about GI as being overlapped in that as far as how well we're detoxing. All the nutritional components we talked about in the lectures are based on, how adequately you're able to make thyroid hormones, or, all those little variables, all those cofactors that are optimizing or helping with detoxification. So I guess that's how I would kind of tease apart as best I could the endocrine and the endocrine system and how I focus on it, but knowing that they're all interrelated for sure.
Christian, your thoughts?
Yeah, I mean, I agree. They're obviously it's all related, and yes, the tests are technically separate depending on what you're looking for. I mean, you're going to get a stool analysis, you're going to get some salivary and urinary testing, and if that individual has a very specific chief complaint or degree of symptomatology where you can get that focused and say, hey, this sounds very much like X and we're going to do this test. But that's not the luxury that we always have. So you need these complex testing platforms that kind of overlap a lot of these systems and allow us to get more data points. Hence the Endo Plus kit that we're talking about is really kind of the convergence of all the data, and even has some degree of gut information. And you can always get a GI test, but every single new patient that I see in my clinic, and this is just my personal take on how I practice, every single patient I see, no matter what their chief complaint is, gets a GI effects and an ASP or adrenal stress profile. And I have to date, and this is year 6 of my practice, that I have seen one that's normal right off the bat. I mean, everybody has an abnormal result for each of those as their starting point, as their baseline. So we work on that. With regards to how it's all interwoven, I mean, the coolest thing is when you're doing tests and you're establishing foundational kind of lab testing objective data on a patient, and then you're kind of honing in on why they're there and enacting some sort of treatment strategy for that. And you then along the way see results that were normal or suboptimal start to get even better when you're not even directly doing anything about it. Like thyroid function comes back, it's within the normal range. Maybe it's not optimal, but they're not overtly symptomatic. And we start working on their stress in their gut, and their thyroid gets even better. And they're like, wait a minute, how'd that happen? Well, because we got the system better, right? Like when the system itself gets better. And we talk about in my practice a lot, gut and adrenals being kind of the key strokes, because a lot of stuff you'll get close to the finish line, but you're not going to get it across until those systems get right. And I often say when they do, 80% of the problem, regardless of what it is usually solved. And the other 20% is individualized and specific. And it's kind of going back to that 80-20 rule, but you get their adrenals and that HPA axis right, you get their gut right, and so much other stuff just auto corrects without you being specific about it. So I can't hammer that home enough, and it's just seen over and over and over again. And I think that's really the point of the system of systems approach, or the biological systems approach.
No, that's powerful. That really is. That's lasered in on takeaway value. So, Michael, I'd like to jump over to you. And Christian just mentioned 2 tests. For the sake of clarity of some of our listeners that may be first time really hearing this information, could you go into those 2 tests a little bit just to clarify what they are and what they do?
Yeah, absolutely. So talked about our GI effects. It's our stool test here at Genova. It's our most comprehensive GI analysis that we have. We've been kind of building, and doing a lot of work on that for many, many years now. And so on that, you're going to get overall evaluations for how well your GI tract is digesting, absorbing, even sub breakdowns, like not only just, can I digest fats well, but like which of the fats are digesting. We're looking for parasites both via PCR analysis as well as through microscopy. We're doing all types of things to assess the microbiome, whether that's a culture analysis. But I think one of the most fascinating things for us, and I think where the field's growing, as we've talked about before, Dr. Bland, is really understanding the complexity of the microbiome based on data analysis. Because I think what we're learning is that, everyone's microbiome to a certain extent, no matter where you live, no matter what your genetics are, no matter where your family is going to look a little bit different. Everyone has a little bit of a different baseline, but at the end of the day, those different microbiomes are probably creating the same functionality. And so understanding what types of dysbiosis are related to inflammation or related to poor production of short chain fatty acids that are good, that's really where we're focusing a lot on understanding the future of the microbiome. So that's the GI effect stool test. And Dr. Jinsky also mentioned the ASP, which is our adrenal cortex stress profile. That's a salivary cortisol test. We measure cortisol diurnally, so usually 4 points throughout the day. There's an option to add on what's called the cortisol awakening response, but really we're checking there for both short-term and long-term stress and how that's impacting the body. And so typically we like to see high cortisols in the morning to wake us up and get us ready for the day, low cortisols in the evening to prepare us for sleep. And a good cortisol curve is typically what we're shooting for. And as that curve starts to flatten in response to long-term stress, we see correlations to all sorts of dysfunctions up and down across all various organ systems. And that just goes back to what Dr. Zinsky was saying as far as stress has a major influence on negative health outcomes. And, it's like, as much as we talk about that in the collective consciousness, it's almost like we still don't talk about it enough because it's just so important. So those are the 2 tests in general that was referenced there.
You mentioned just briefly in passing different levels of specificity that one can test for the GI microbiome, and you mentioned just in passing metagenomics analysis, where you start to really detail individual species. And how valuable is that? Where would that find a role? And it seems like there's different thresholds that we could use to get to interrogate the GI microbiome.
Yeah, I think in an ideal world, all of these types of methodologies are going to prove their benefit. And so whole genome sequence or metagenomic sequencing is a really great tool that we have as well. We have a test called the microbiomics, which is a whole genome sequencing test. And with whole genome sequencing, just so people know how that's different from maybe other ways to look at the microbiome, is that it is literally looking at every single organism in much higher level of detail than you would get through maybe like a qPCR or certainly through a culture analysis. And so you're getting basically a fingerprint of the entire microbiome. And when you get that, then you really have a great ability to predict the types of things that the microbiome not only has in it, but what they're doing. Because I think really what we're finding is at the end of the day, it's more important what the microbiome is doing. What are the good products they're making? What are probably some of the negative products that they're making? And how can we shift that? And so layering in all of those different data points is really where we're going to get the most comprehensive understanding and try to limit as much as we can some of the assumptions. One thing about whole genome sequencing too is, we're making some predictions about what that microbiome might be doing based on who's living there. But on the GI effect stool test, we're also directly measuring some of those things that the microbiome makes, like short chain fatty acids. And like Dr. Jinsky talked about, beta glucuronidase feeding back into hormone detoxification. So that's a little bit of kind of hopefully that was simplistic complexity, but that's kind of what we're
Well,
driving to.
that was very helpful because that's a very complex topic. Obviously, you've got hundreds, well, probably thousands when we include every living species, fungi and protists and so forth in your GI milieu. So this is a pretty complicated topic that lots of people are investigating, and I would say we still have lots to go to really understand it, but I think you've done a very good job in kind of making it accessible to us. So Christian, when you have a patient and they're wanting to find a solution to their chronic problem, their health problem, obviously you make all sorts of different kinds of assessments about the severity, duration, and frequency of their problems, and good history and physical. And then you probably also interrogate how much can that patient afford to do. Some people want to do the whole kitchen sink, and others might say, no, I got to back into this carefully because I'm, for whatever reason, maybe cost constrained. So how do you gauge that? What goes into your decision-making process?
Yeah, so the goal obviously is ultimately to be as personalized and precise as possible. And the way that we have set up our practice is that it's a membership-based practice, but we use insurance so that we can get expanded lab testing and often covered by insurance, which is fantastic, versus a fee for service where they're just kind of picking off of a menu. And yeah, cost is prohibitive. It always has been, and until things change, it will be, and that's problematic for many patients. But I tell them all the time that if plan A doesn't work, then we'll go to B and then C, and we'll work all the way down the alphabet, and if necessary, create a new one. I mean, the goal is to continue to plug along and do things that they are able to do. And so each patient gets a 2-hour initial intake, which is an extensive history, physical, having a conversation about their environmental and other exposures. And all of that's kind of uploaded when they're onboarded, which I review before I sit with them. Then I sit with them for 2 hours, and then we do testing based on their complaints. As I mentioned, everybody gets a stool test and an adrenal stress profile, some blood testing, maybe more kits depending. And then as that data comes in, I'm signing off on it and giving them some semblance of a plan. And it's either sit tight, more to come, or make these lifestyle changes, or please incorporate these supplementations or medications. I mean, I think a common misconception is that functional integrative medicine is anti-prescriptive medicine, but the reality is that I'm pro-thoughtful medicine. I'm not anti-meds. I was an ER doc for 20 years. I saved countless of lives with medications. So, if you're using medications appropriately, then they're absolutely powerful. And that means factoring in things like minimal effective dose, shortest course, side effects and nutrient deficiencies, as well as interactions with potentially some of the botanicals you might be using. And then you can do it thoughtfully and appropriately, and patients get better. And again, that saves on cost because you can run it through insurance. We also compound and use compound pharmacies. And so it's very individualized with regards to what they want to do. And some are like I was when I was a patient, all in, just point me in the direction and I'll do it. Whether it hurts or not, I want to get better. And then there are others that have to go really slow and methodical, and that's fine. And they might start one new thing over the course of 3 to 5 days to make sure they don't react, and then escalate the dosing until they're tolerating it, then move on to the next thing. It is absolutely okay for any of these because it's each individual's journey, and it's up to them to decide and teach me how they best work. I'm not rigid in any way in that regard because that's not how this is supposed to be. And so they guide me, I teach them, I inform them and translate their data, and then collectively we meet in the middle, and they hopefully get better, which is usually the case.
Well, I'm really inspired by both who you are and how you describe what you do, and I can only imagine the benefit that your patients get just from the way that you examine the complaint and put them into the center of the target, so the patient becomes the focus. And just the way you describe that is brilliant. So
thank you.
Good on your patients. They chose the right doctor.
Thanks.
So Michael, any comments that you wanted to add to Christian's thoughts?
Yeah, no, I really appreciate that. And it's kind of interesting too, because after graduating from Bastyr, moved to North Carolina, which doesn't have naturopathic licensure. So for a good bit of time, the people that I was working with, I was very limited in the capacity as far as what I could evaluate with them. And so I think one of the things that I really, the way I place testing, and especially with people who might have some issues around cost, is that testing is really, really great for motivation. It helps people track where they are. It helps give them motivation and encourage them why they might want to consider some of these lifestyle changes and some of these things that we're recommending. It's also really wonderful at uncovering things that perhaps we weren't suspecting. And so that's a really great clinical utility for the testing. But I can speak from experience when I was working with people and not having the capacity to order myself, is that we have such great tools in general. And if you are thinking critically with people who are coming in and you are understanding kind of the systems and the models, you can do a lot of incredible work for people who don't have the capacity or perhaps the money to be able to afford, each and every single test that's available. And so focusing on the foundations, coming back for me to my naturopathic roots and saying, look, what's going on in the system? What can I see already from the system just by this person walking in, how they're walking, the way they're holding themselves, what they've told me about their diet, what they probably haven't told me about their diet, what they're telling me about their social life. All of those capacities, we have such great ability to impact a lot of change. And if we keep going back to those fundamentals and also focusing in on why the person isn't doing what oftentimes they already know they probably could or should be doing, and really drilling down into that bit, you can create so much change that, at the end of the day, like Christian was saying, if you just work on the GI and adrenals, you're going to get 80-20. I mean, we can do that already, even at square one when the patient walks in the door.
Yeah, I would build on that and say that ultimately clinical correlation is great and should be applied, but it doesn't always happen. And for instance, I have patients that claim to have no GI symptoms at all, and they have the worst stool results. Like their GI effects comes back like a train wreck, and then until you learn what their extraintestinal manifestations of that dysfunction is or are, then you can start to draw those clinical correlations. But up until that point, you don't have that knowledge. Same thing with an adrenal stress profile. I have the patient who tells me, yeah, I don't have stress, which is rare, but some say it. And then we get their ASP back and it's a low flat curve with no DHEA. And I'm like, you told me you don't have any stress. They're like, I don't. I did this and I was at home. I was off. I was completely relaxed on this day. And I said, that's a problem. You're not able to feel this. And we can't really clinically correlate this. And so therefore, objective data is incredibly useful because this is a ticking time bomb. So you start to work on that patient. And the beauty is as they grow in the understanding of their own biology and start to listen to it, they can pick up on the subtle signs and draw those conclusions, and you start to see all these aha moments happening. And you don't have to test as much at that point in time because they now have that experience from which to pull. Hey, I remember when, and then we did this, and then I got better. Sometimes they just do it on their own and then tell me about it in the aftermath, which is the best medicine. And I'm just hearing about them kind of self-healing. And then sometimes it's really, hey, this feels like my SIBO again. What should we do? And I think that's really the goal of all this, really, is to just kind of meet them where they're at. But testing is sometimes just more powerful than you could possibly imagine.
Yeah, thank you. I'm reminded as you're talking of way back in my history, when I was just starting, I had the privilege of meeting Hans Selye up at McGill before he moved on. And he was the developer of this whole concept of the stress adaptation, the general adaptation syndrome, GAS. And he was saying, a lot of people run out of gas, they run out of GAS. So they go through arousal, and then they go through an adaptation. And that's where they say, oh, nothing's wrong, I'm fine, but their body's working really hard, like a hummingbird at the flower, to stay stationary in that adaptation phase. And eventually that reduces their reserve if they don't do any repletion. And now they go into falling off the edge, which is exhaustion. So that's the 3 stages of the GAS, you run out of gas. So I think that we can't be deluded sometimes by the patient saying, yeah, well, I'm fine, no problem there, until we start reminding them, are you sure there's no problem there? How about your sleep? How about your waking? How about your cognition? Well, yeah, I am going to sleep in the middle of the day for a few minutes. Those things start to pop up. So I think what you just said is very, very enlightening. Well, I want to thank the two of you. This has been a really important course, and we're so privileged to work with Genova and putting this out, because I think this endocrine symphony organs of communication metaphor is a very powerful way for people to think in systems. And I think, Christian, you do a superb job of both as a practitioner and as a thought leader, communicator, and getting that point across. And Michael, it's always a pleasure to speak from the center of where lab testing is being done in this area, and see the quality and educational intention that Genova has. I think it's one of the value adds of the lab is people like you that really bring a high level of academic rigor to what you're doing and bringing that to the customer. So I want to thank you both, and be well, and we'll be checking back here over the time in the future and seeing how things proceed.
Thank you so much.
Take care.
It's been my
Thank
pleasure.
you. Take care.